Thank you all for coming today. Very happy to see you. My name is Emily DeRose. I'm one of the co-chairs of the Pediatric EMS Symposium. So this is our second annual adventure into Pediatric EMS, having a one-day Pediatric EMS conference to combine with lecture and hands-on skills event. Really well, it was well received last year, so back by popular demand, we hope that. I work at Children's National. I am a nurse coordinator in the emergency department here, and also at our Southeast campus. Part of my role is to be the EMS coordinator and the base station coordinator, which means that any patients who you negative, that I would love to hear about those things as well. So I keep in contact with the jurisdictional QA officers who most often transport patients to us, but individual providers reach out as well. I'm happy to provide my contact information to everybody who's here. I've seen her throughout the day here as well. So if you saw any of these announcements come up, they are just a little bit of kind of housekeeping for the day. So if you go out the door and make a left, then have a brief break in between each lecture to get set up for the next session. So you would be able to use those facilities during that time as well. So everybody should have received a folder when you signed in. First of all, when you signed in, it's important that you provide your state provider number, because for Virginia, Maryland, and DC, we are able to provide continuing education, but we need your state-specific or district-specific EMS provider number written legibly so we can make sure that that all happens. Also, at the end of the day today, you will receive a certificate that you can also use, because that is required especially for any DC EMS folks. So we will make sure that all of those things get submitted so that everybody can get their hours for spending their Saturday with us. So if you have questions at any time, please talk to any of the instructors. You will see Cindy and myself facilitating today, and we also have our EMSC program manager, Chris Page, is here as well, wearing an EMSC shirt, so he's happy to answer any questions as well. New this year, we're very excited. We are offering a live streaming option for the lecture portions of today. So hello to our live stream participants. We're very happy to have you join us today. And then our colleagues in the back facilitating that, if there's anything that we need to do, if they can't hear us at any times, we may pause, but we're hopefully off and running with that. So everybody got a folder, and in that folder you have an agenda. So the folder color itself is important. It divides you into 3 groups for the skill stations. So everybody gets to do all skill stations in the afternoon, but we divide you so that a third of the group is going to be red, blue, and green. Depends on which skill stations you go to first, second, and third. So on the reverse side of the agenda, it tells you the locations and the order of the skill stations that you're going to go to based on the color of your folder. So please adhere to that. If you find a neighbor to switch with because you want to be in a particular group, that is fine. But we do really want to keep it even, so try not to have everybody from one station or one jurisdiction try and be in the same skills group, just so we can make sure that everybody has the best learning. I think that was everything that I needed to cover. Oh, one more thing. The evaluation. There's an evaluation that is in your folder if you were here in person. Please give us back the evaluation at the end of the day. Please be very thoughtful in your responses. We really took the feedback from last year and made changes, or even had this conference again because of the feedback that we received. So your honest and thoughtful feedback on those evaluations. All of our speakers and all of our instructors are here volunteering today, so they're here out of a passion for pre-hospital and EMS and a passion for pediatrics. So we hope that that will shine through today and that you'll have a great experience learning from their various areas of expertise. So the evaluation, you will hand one to us at the end of the day and we will hand you your certificate. So that will be kind of your ticket to get your certificate. And for the live streaming options, they will they will click, there's going to be links to follow on the live stream to the evaluations and to the sign-in to make sure that you get credit for those things. Okay? So, I'm going to introduce our first speaker. And hopefully pull up your slides here. So I can't get your finger.
Okay, that's okay.
So our first topic, pediatric traumatic brain injury and concussions. So Dr. Chisom Agbim is a second-year pediatric speaking at this.
Okay, so thank you for having me. As stated, I'm a second-year pediatric emergency medicine fellow here at Children's National. I also have a strong interest in disaster preparedness, so hopefully everything makes sense to you. If at any time you feel that you have a question, please raise your hand. I'm more than happy to stop and answer. Okay, so pretty much our objectives for today are to review common injury patterns and pathophysiology of traumatic brain injury in children. With that, just evaluating the pediatric pre-hospital protocols, and then also comparing and contrasting the prognosis of traumatic brain injuries in all children. Okay, so for disclosures, I have nothing to disclose, except there will be audience participation, so hopefully the coffee is kicking in right about now. Okay, so just some food for thought and just for show of hands, the human brain doubles in size by the age of, and these are your possible answers. 4 weeks? Who thinks 4 weeks? 6 months? Anybody for 6 months? Okay. 3 years? 3, okay, a little more. 10 years? Or 18 years? Okay. So pretty much it looked like 3 years, but the answer is actually 6 months. So within just a short amount of time, you have the pediatric, especially the pediatric patient, you have for the human brain doubling in size by the age of 6 months. So just some basics about traumatic brain injuries in pediatric patients. First, we'll go over some mechanisms. So most commonly, you'll have a hit or blow to the head. This mostly results in coup contra coup injuries. So the coup injury is going to be the injury that's on the same side as the initial impact, and the contra coup is going to be the secondary impact injury, which might just be bruising on the opposite side of shearing forces, and those are going to result in more micro-tearing type injuries, so not necessarily injuries that you would immediately notice on head imaging throughout the brain. So for injuries, they'll be things like contusions or brain bruising, lacerations or mechanical tears to the brain, hemorrhages, which could be subdural or epidural, bleeding within the brain, or midline shifts, which result in pressure that actually pushes the brain off its midline axis. For diffuse injury, the most common is diffuse axonal injury, and this is just a micro injury associated with tears to the neurons. So you might not necessarily see anything on head imaging, but then this could result in anywhere from headaches to symptoms to comatose symptoms. So we see this in pediatric patients, not a lot, but it does occur. More commonly would be cerebral edema, which is just overall swelling throughout the brain, or sometimes it could be oxygen that is cut off. Oxygen is cut off of the actual brain. Okay. All right. So most importantly, we'll go over clinically important versus minor traumatic brain injuries. Have you heard these terms just? No. Okay, so we'll go over the definition A clinically important traumatic brain injury is going to be a traumatic brain injury that causes death or injury that necessitates a neurosurgical intervention. Hematoma evacuation, so actually cutting portions of the skull to evacuate accumulating blood that's pushing down on the brain. It can also just be an injury that results in the patient needing to have endotracheal intubation for more than 4 hours, or even just hospitalization for greater than 48 hours. When we look at minor traumatic brain injuries, these are going to be also injuries, traumatic brain injuries, but they don't necessarily result in mechanical injuries that are causing loss of consciousness for 30 minutes or less, confusion, amnesia, or even a GCS initially of 13 to 15, 30 minutes following your injury. Okay. Does that make sense? Okay, so why are children at more risk for traumatic brain injury? Anybody have any ideas?
Well, their head is pretty big and the body is kind of small, so big head.
Yes, really, really big head, really small body initially. Anybody else?
Weight and the difficulty.
Absolutely. So yeah, the big head, this weak musculature, also resulting in kind of wobbly effect, which is going to be more predisposing to falls. Okay. Anybody else? Okay, we'll go through. So we did talk about the big heads in relation to body size, the weaker necks. Also the scalp being more delicate and less able to absorb injury, specifically in your very small patients, your infant patients. A proportional impact of injury. So we talked about the big head kind of being the focal point as to the fall. Developing brains, overall pediatric patients, while they're growing and while they're developing, all of these connections are being formed, and then that also predisposes for more risk of injury. Developing curiosity, so we can't forget about our adolescent patients, so often taking more jumping off of things, especially in adolescents, but then also in your young children. Okay. So how do most head injuries occur? So just breaking down the numbers, in ages 0 through 14, the CDC has found that the most common results, the most common cause of these of traumatic head injuries would be falls, followed by struck by or struck against events, motor vehicle accidents, also refers to things more with shaken baby syndrome as well. And then there's a whole other category that is just unknown or other. Kind of a accumulation of all sorts of things. They didn't really specify going through. Okay, so what does that mean for us? Big number here, so 837,000 brain or sometimes. So while pediatric brain injury is quite common, it's actually good to know that of that number, the clinically traumatic portion, only about 0.02 to 1%. Start off with the case. So you're responding to lacerations. He's lying in a pool of blood. Okay. What are your next steps? So what are we thinking? Anybody? Airway, so assessment, the main things that we're thinking about now. So that being said, looking at our general assessment and universal care would start with the pediatric assessment triangle. So right when you see the patient, this is a good tool to use just to see if they're sick or not sick, or just your overall general impressions of the child. Is the child laying down? Is the child walking around? Is the child inconsolable? Is the child posturing? Things like that. So really what we're looking for here is not a full assessment, but just looking at the appearance of the child, the circulation to the skin. So are they? Absolutely. So suctioning, jaw thrust maneuver, so opening the airway like we said. Then also, if necessary, thinking about applying an oral airway for this child. And then for the breathing, we find that the child has bilateral shallow breath sounds and a respiratory rate of 15. Okay? What do we think of doing? Okay. So we could think of and possibly assisting breaths with a bag valve if necessary. Okay, and then for circulation, you find that the pulses are 2 to 3, heart rate's 160, and the patient has a large scalp laceration with active bleeding. What are we thinking of doing? Pressure, so trying to stop the bleed. What about this child actively bleeding? Is there anything we could do to help replete? Pressure to the wound, IV access, and then thinking about bolus fluids. All of this being said, trying not to delay the time for transport to the hospital. Okay, so for disability, you find that this 3-year-old patient's responding only to painful stimulation, the pupils are equal but sluggish, and the patient is persistently crying. So looking at that, what kind of score would you want to give the patient? What kind of tells you the mental status of a patient? Okay, so we could do the GCS score, or we can do AVPU. So for this child, I would say that the child is opening their eyes spontaneously, persistently crying or screaming, so that would give you a score of 3. So right now we have a total of 7, and then localizing pain. So your overall GCS for this patient initially on the scene would be 12. So GCS is really helpful to us while we're in the hospital, just to know what the patient looked like at the scene, because by the time they arrive to us, sometimes they're better and sometimes they're worse. But unless we have that initial assessment, we're not able to kind of know which way the patient is going. Okay. So some interventions that we talked about previously are applying some spinal protection, and then may need to intubate if further declining. So what's the GCS that we think about for intubation on scene? GCS less than 8, we say intubate. This patient's not quite at that level, but that's something to be about. Okay, so just talking about spinal precautions, how would you know whether to use spinal precautions or spinal immobilization measures? So we'll kind of break it down into spinal precaution versus spinal immobilization. And this refers to the protocols both for Maryland and for DC. So for spinal precautions, that refers to protecting the spinal cord from further injury. So what that implies is just the application of a rigid collar, securing the patient to the stretcher, and then trying to reduce the transfers and stabilize if it's necessary to move the patient. For spinal immobilization, this refers to the act of placing a collar as well as using a backboard to prevent excessive movement to the spinal column. Just a reminder, infant or child car seats may not be used as spinal immobilization devices for the pediatric patient. Okay, so just breaking it down for the DC fire. Pretty much for patients that have a high energy mechanism of injury, having some focal neurologic findings, any deformity of the spine, or if they're unconscious or have an altered level of consciousness. For spinal precautions, there is a pathway. For our patient, the first question would be, is it a low mechanism of injury? For this patient, falling from 2 stories, about 20 feet is no. So that automatically would tell you to immobilize the patient. If you refer to the Maryland protocol, spinal immobilization is similar, and then precautions also follow a protocol pathway. There's some more questions in the Maryland protocol, but if this patient does have an altered mental status, and kind of on the lower half of the screen, it's referring for a child that has not reached their 15th birthday. So this patient hasn't yet reached 15th birthday years and blood coming from the right ear. Any concerns? What was that? I can kind of, yes, skull fractures. Absolutely right. So just talking about basilar skull fractures, high impact injuries, although overall they're not as common. So some signs could be the battle sign, which is the bruising behind the mastoid process, or bruising behind the ears. Raccoon eyes, so that's when you have the bilateral black eyes. You can also have CSF fluid that's coming from the nose, or any kind of cranial nerve palsy, meaning focal neuro exam, especially on the face. Bleeding from the nose and ears can indicate this, but of course not every nosebleed is indicating a basilar skull fracture. Blood behind the ears are then if they have any signs of deafness or vomiting or nystagmus on exam. Okay, so we're going to practice what we would say as we're calling into the hospital. Does anybody want to give it a go with our patient? Pressure. Anyone? Okay, I'll do it for you guys. So your notification to the hospital is going to say something like this. You have a 3-year-old male fall from second-story window, distance of about 20 feet. Patient with a large scalp laceration, bruising behind both ears and blood coming from the right ear. GCS is 12 on the scene, oral airway in place, pupils are sluggish, heart rate of 160, 1 PIV placed and running a normal saline bolus. ETA 10 minutes out. Okay, so this is pretty much what we hear when we pick up or accepting these calls, and then what we're looking for is our keywords. So this highlights the things that are really important to us. So age, first of all, knowing that it's a 3-year-old patient, the mechanism of injury, a fall, the distance of 20 feet, and then other signs of injury, so scalp laceration and the bruising behind both ears is important to us. Initial GCS, oral airway, or if the patient is intubated, it's important to note. The heart rate too, although we would expect that this patient's most likely crying, so it kind of gives us a clue as to what's happening with the cardiovascular status, but not as much. And then any other interventions that were done, such as a PIV placed, and then your timeout, okay? So then when we hear this, what we're thinking about is mobilizing our hospital resources. So we have different criteria that fit how we call a trauma at Children's National. So for this injury, mostly they follow rather mechanisms of injury, or they follow interventions on the field. So for our trauma stat and our trauma transfer criteria in this patient, you would see that the fall from a height greater than 10 feet would indicate you to call a trauma stat. So this is stuff that we pretty much look up when we're talking to you guys. It's not innately memorized, but we can tell what kind of resources we would need based on the mechanism and how the child looks on the scene. So for this one, we're going to call it a trauma stat. So we then assign it, and then we page it overhead, and then that would prompt all people that are mobile within the emergency department to get into the resuscitation bay and wait for the patient to arrive. If it is a trauma stat attending, which is a higher up criteria, this would be things like if the patient was intubated or had an advanced airway, or if the patient had an open skull fracture with the kind of similar, and sometimes they can be graded or they could be updated based on how the patient looks upon arrival, or the patient looks when they're being transferred. Okay, so for our trauma bay preparation, when you guys arrive to our trauma bay, you might see a lot of individuals around. So pretty much we'll have a respiratory therapist, an anesthesiologist, a resident, and a surgery coordinator. These are primary and secondary survey. We also have a right and left, and then a med nurse in addition, and radiology would be standing by. We personally at Children's National, us being the emergency physicians, we co-run the traumas here with our surgery fellow, which is our surgical coordinator. If it is a trauma attending, then we can call it backup help, which would be the attending surgeon who's on call, as well as the PICU fellow. And then if we do have enough time in advance, we also have time to call necessary subspecialties. So sometimes we would need neurosurgery to assist us, and we can call them down and have them prepared. So pretty much the more in advance we have the notice, the more we are more prepared to set up for the patient. Okay, so what can you guys do en route to prevent further injury? So maintaining a normal ICP and then low stimuli while en route can help with this. Also maintaining normal blood pressure, so turning up the heat and throwing on some blankets can go a long way. And then ensuring adequate oxygenation. So this would be providing a non-rebreather mask with 100% O2. and then also bag valve mask ventilation if necessary. Okay. What we're trying to prevent, or what we're working with en route is something called the Monroe-Kelly Doctrine. So has anybody heard of this? Okay. So what it is it pretty much boils down to an equation that will herniate. This would equal death. Okay. So we'll review the protocols again about managing possible herniation. So if there's signs of herniation, which would be unequal pupils, posturing, paralysis, seizure-like activity, or periodic breathing or Cushing's triad, or if the patient is rapidly decreasing in their GCS, or there's an online medical consultation that tells you so, you'll need to hyperventilate the injured patient as follows. So for Maryland, is anybody from Maryland here? What's your hyperventilation for pediatric patients? Do you remember?
30 to 35 or they're instated around 3.
Okay. So for looking up the protocol, if they're greater than 13, 20 breaths a minute. If they're 1 to 12, then that will be 30 breaths per minute, and if they're less than 1 year, that'll be 35 breaths a minute. Yeah, so differs depending on the age. And then for DC, do we have anybody from DC? Okay. For DC, does anybody know the protocol? It's a little bit more simple. So that would be, if you're an adult, you would breathe at 20 breaths per minute, and if you're pediatric, automatically you're just 20 breaths per minute, unless otherwise directed. Okay? So 10 minutes after you arrive to the hospital, the patient becomes unresponsive and declines to a GCS of 7 and is intubated in the trauma bay. Neurosurgery was at bedside and ordered a stat non-contrast head CT, and this is what you see. So pretty much you have a subdural hematoma, and then you also can see that the brain is dramatically shifted. So you have what we call a midline shift. So for that, that requires immediate neurosurgical evacuation. The patient successfully undergoes that, and then they're on the PICU on their way to recovery. So nice work. Okay, so for the next part of this presentation, I'll just focus on mild traumatic brain injury. So these are injuries that are a lot more common. Oh.
When you were talking about the in-route care, I understand the need obviously to guard against hypoxia, but what about preserving the pressure, keeping it systolic, always at 100 because the RCP or?
Yeah, so overall, the most rapid during transport is going to actually be manipulating the breast and how much you give. You can be giving fluid boluses, but automatically the vasculature is going to change and it's going to change within the brain when you are assisting breast. So that would be more of an impact than trying to give pressors or trying to give extra fluid boluses. Those also would work, but in the meantime, that is going to be your quickest change for transport. Okay. Any other questions?
What about pain management?
Pain management is important. So if you can give IV pain meds, or if you can give, for pediatrics, Tylenol, a suppository, that would also help as well. Anything to kind of get the child calm and to relieve that pressure would be good. Okay. All right. So just switching to mild traumatic brain injury, I'll start with a case. You have a 4-year-old male sitting on a tire swing. He is 2 feet above ground when his brother pushed him and he fell backwards and he hit his head on concrete. He appears dazed for a few seconds and then cried immediately afterward with no loss of consciousness or vomiting. He had a 3-centimeter hematoma, so just a knot on the back of his head, but no palpable bony step-off, so you don't really think it's a fracture. He's complaining of a headache. So this is really typical of a lot of the kids we see in the emergency department. Our question would be, will this patient need head imaging? So this is a question that we get from parents, and a very common one too, because we have a lot of these injuries. But one of them is, do all children with head injury get a CT? The answer is no. So for us, we try and minimize head CTs because of the radiation risk. So unless it's absolutely necessary, we try not to image every single kid who comes in with a head injury. Part of that is part of the image campaign, which is a nationwide campaign, which is for children and adults as well, but mostly for children, in an attempt to reduce unnecessary head imaging or imaging in general. We decide whether the patient is high risk, medium risk, or low risk for injuries, and whether we want to go ahead and get that imaging. So for that, we use something called the CT decision guide, which would stratify patients by ages less than 2 years and 2 years and up based on their clinical symptoms. So this is just an example of the algorithm, and we look it up all the time, so this is not something that needs to be known, and you can easily Google it if you're ever in doubt. But pretty much it walks you through an algorithm where initially you'll start here. So if the patient had a GCS in 15, a skull, and this is for patients under 2 years. I'll go to the over 2 years next. But if the patients had a GCS less than 15, a skull fracture that you can actually feel, or altered mental status, if they had yes to any of these questions, we'd put them in a high risk category, which is about 4.4% risk of a clinically important injury. So if you remember, clinically important would be something that would possibly need surgery to intervene with. It's about 4.4% at that point, and then they would get head CTs. For the patients that don't have any that otherwise are normal, we go down to another set of questions. So we ask, is there a scalp hematoma? If the loss of consciousness is greater than 5 seconds. This is usually by parents telling you, so sometimes you'll have to decipher whether it's greater than 5 or less. If the patient's not acting normally, or if there's a severe mechanism of injury defined by false, if it's a motor vehicle accident, bike versus ped, are struck by high impact. If there's yes to any of those questions, we call them intermediate risk, which is a 0.9% chance of a clinically important traumatic brain injury. And for those patients, we can rather observe them in the emergency department, usually for about 4 hours, or we can go ahead and get the CT. And this is shared decision-making usually with the patient's parents, are usually based on your gestalt of how serious the injury was. If the patient is otherwise okay from that, they go into a low risk category, so that moves down from 0.09 to 0.02. CT is not indicated in that time, but you will observe that patient for about 4 hours. If everything's normal, then the patient is at discharge criteria to go home. Okay? So just differing for the patients that are 2 years and older, we still start out with GCS, signs of basilar skull fracture, AMS. If there's any yeses to those are high-risk patients. That's about a 4.3 risk of a clinically important traumatic brain injury. If not, then we ask for other things. So we ask for vomiting, loss of consciousness, headaches, and again, severe mechanism of injury. The severe mechanism of injury is the same with the exception of now the fall is greater than 5 feet for these patients. If there's yes in any, again, going to observe versus CT with a risk of 0.8% of clinically important traumatic brain injury. And if not, then we'll just observe those patients and they have a less than 0.05% chance of clinically traumatic brain injury. So as you can see, there's not really that high of a risk in general, but we can stratify patients, and this is proven. We can stratify patients to see who has the highest risk and who we're actually going to have a head CT. Okay, so what if the patient doesn't meet your criteria for a head CT, or what if it's negative, or does that mean that there's nothing to worry about? So again, just looking at clinically important versus minor, we're now dealing with the minor traumatic brain injuries, so those are also synonymous with concussions. So clinically important, of course, we would involve our surgical partners, but for minor, we actually have a different pathway that these patients go on. So for concussion, just the definition is a clinical syndrome of biomechanically induced dysfunction with no apparent radiographic injury. So just because the CT is negative doesn't mean that the patient does not have symptoms. I think that's the main thing that parents are concerned for when they have patients with concussions is, I need a CT or I need some imaging to prove that. A lot of times it won't. So a lot of patients that come in, we're actually talking them down from getting that. Okay. So for recovery of mild traumatic brain injury, it's variable. Yeah.
Somebody online asked this case in particular and said if the pre-hospital team showed up and the parents didn't want that child to go to the hospital,
Then
would you counsel them? What would you do?
The patient, yeah, so if that happened, the patient should still come into the emergency department. Usually we would try and stratify those patients, so we'd use the PCARN algorithm to see whether they were high risk or not. A lot of times we do end up observing the patient and then talking to the parents and telling them why we're doing what we're doing. But it does happen, not commonly, but it does happen where parents would refuse a CT and we feel that they need them, and then sometimes it's in that gray box where we can discuss.
So I think what they're asking, so we show up on the scene, the patient, looks pretty okay. No loss of consciousness. He's saying that the family saying, yeah, we don't want to go. We're home. So we have to wait to be back.
Definitely. So I would encourage the patient to go. If the parents are calling in, we also cannot give advice based on that PCARN criteria without seeing the patient. So it's always a good idea to encourage them to go in and not just to kind of use this as an at-home stratification to justify not going into an emergency department.
If you consult with your base station or with the trauma center, they can get any physician online to help speak directly to the parents. If they, sometimes that can be helpful if they're like, this is a physician at the hospital telling you that your kid does, need to be seen or maybe doesn't, then it kind of takes the pressure off of you to make that decision or helps give you another person to try and help convince them. So you can use those resources as well.
Absolutely. Thanks, Emily. Okay. So, great questions too. So going back to recovery, for these concussions/mild TBIs, usually they resolve within 1 to 3 weeks is what we tell patients, and then they're referred to subspecialists if those symptoms last greater than 4 weeks. So again, those symptoms could be anywhere from like daily headaches to confusion, visual deficits, or just kind of feeling overall irritable. So any of those that persist past that 4-week period, we consider that patient needing subspecialist follow-up. Some risk factors for prolonged recovery include an older age, a previous history of getting a mild traumatic brain injury, lower socioeconomic status, learning difficulties, family stressors, or even neurological and psychiatric disorders put that patient at an increased risk to actually have prolonged symptoms. So what we do for discharge and outpatient follow-up is we try and offer very clear instructions, verbal and written, about returning to activity and what to expect, and then also customized to the patient's symptoms. So after we tell the patients now, especially with the new guidelines, the heads-up guidelines by the CDC, to rest for 2 to 3 days and then begin light activity and gradually increase those activities. Once they're back to non-sport activities, they can return to school, and then they're not to return to contact sports until symptom-free and cleared by a physician. So this is just an example of our post-concussion home instructions that we give our patients. Usually the different bars indicate when to seek urgent care, especially if the patient's having severe symptoms, even in less than the 4-week period, and then common signs and symptoms they can expect at home. And then there's also something called second impact syndrome, which some people, it's a controversial topic, but the whole term is used to describe a syndrome in which an athlete suffers a concussion or a mild traumatic brain injury, and then within a few weeks suffers another one, which can result in cerebral brain swelling, herniation, or death. So it's a pretty serious symptom that has been reported in the literature, and started in 1984. What we do know is that it's an unknown mechanism of action, so still to date we do not know how this is happening. It's unclear whether it's related to truly the second impact following the first one, or whether the second impact was just alone within itself was enough to put that patient at that risk, and then younger individuals are at risk by the literature. So for DC, we do have Athletic Concussion Protection Act that was passed in 2011. This is similar to 48 states and Chicago who passed legislation similar to this, which states that an athlete can only return to sports if they have written clearance by a licensed healthcare provider in the evaluation and management, who's experienced in evaluating and managing concussions. And this applies to all athletes that are 18 and less in DC. So for the return to play instructions, they're pretty general. There's about 6 steps that are involved in the process. It goes from light exercise to returning to sport. The thing to note that we tell patients is that if you have symptoms that return, at any point you must stop completely for 24 hours, rest, and then start on the step below. So for example, if they're on light aerobic exercise but they start having headaches, they must stop and rest for at least 24 hours and then start at step 1, which is returning to light regular exercise, then then go down the pathway again. Okay?
At what point is there some permanent disabilities from concussions? Is it a number of concussions within a period of time, multiple concussions, long-lasting effects of multiple concussions?
So great, yeah, for children, great question, and unfortunately there's no set period of time that can expose you to such. It could be 1 concussion or it could be many. So there's no data on the number or the time duration of or the symptom duration. So for example, a patient can have the same exact impact of injury as another. One patient can have maybe a headache for 2 days and it goes away. The other can have symptoms for up to 13 months that they're still dealing with. And then those symptoms could be varied. So even in pediatric patients, there's no set risk. So if a patient tells you that they've come in with 5 different concussions from soccer and this is their 6th one, I would think that it would put them at a higher risk to have automatically they're at a higher risk just because they've had previous, but the number of previous doesn't necessarily necessitate that. Okay. All right. So I just wanted to briefly go over treating concussions at Children's National. So we have a concussion clinic. It's called the SCORE program. So the concussion clinic, our SCORE stands for Safe Concussion Outcome Recovery and Education Program, and this is clinically staffed by neuropsychologists who use computer testing to test cognitive symptoms and monitor how the patient is progressing through those. That's a lot better than re-imaging patients, which often is very low yield for seeing how severe their injuries are. So this clinic is open to all patients ages 4 to 22 with a sustained concussion, and then patients usually are referred out if they're having very severe symptoms, or at least 4 weeks and out, and then monitored accordingly. And then for the community, we have a Play Smart Your Brain Matters program, which is an educational component that we teamed up with MedStar to do to educate the community's parents, coaches, and healthcare professionals that might be like sports trainers as to the symptoms of concussion, what to expect, especially when the patient is playing at games, and then when to refer and how to get into this SCORE program at Children's National. We also have resources on the SCORE program website that could be easily printed and dispersed to community centers. Okay, so that is it. So thank you for your participation and listening to this lecture. I'll open it up for questions, but I want to be considerate of you guys' time.
Going back to the hypoxia question.
Yeah.
There's been a lot of argument, don't hyperventilate at all, or just do tight tracking with their entitled. What's children's view as the magic number?
So,
Question, please. Can you repeat the question?
Oh, repeat the question. So the question was about hypoxia, whether there's a verdict at Children's, whether we should just ventilate them as normal, or whether we should do hyperventilation.
Or just track it by the entitled.
Or tracked by entitle. Usually I think it's physician dependent and patient dependent. So we would probably tell you guys to hyperventilate based on protocol, and then we might even switch when the patient comes here as to what the patient's doing. So there's not really a tried and true rule as to what we should do with these patients other than following the protocols that are listed. Okay. All right. Any other questions? All right, thank you.
Is that lighting okay? There's a glare on the screen. Is that better? Great. Friend,
No
this
falling
is
asleep. We have coffee in the cafeteria.
just for the cameras, not for the room.
You said as close as possible. That's okay? Yeah. Thank you. Okay. Oh. Fellow. Yeah. Correct. Okay. Yeah.
What time are you guys starting the next one?
Are you okay starting a couple giving them a
Of course. Yeah.
I think it was 55, but since that one
It was 55, but
well, the hour maybe.
and it was mostly she caught up. It was my directions.
So we have a few minutes to walk away. Thank you.
Yeah, absolutely. Yeah, so you have a couple minutes to visit the restroom or the cafeteria. We'll start and
Here, do you want to speak in the microphone? Am I uploading down here? Okay. Yeah, and yeah.
so she was just
Sorry. And I tend to hover around the desk anyway as a comfort zone.
Yeah. So you don't have to stay here because the live stream can hear you on the
Right.
You would just have to talk loud enough so people in the room can hear you when you step away from anywhere.
Okay.
Or you can have the mic go.
Yeah. Do you have to go towards the screen? I know sometimes you go towards the screen and sometimes you go towards the... Yeah. Maybe, because the blue, yeah, obviously the NYC thing's mine.
that looks like it's red. First I plugged into here and it was like,
Do you want me, yeah, here, if you want to get out of mine and just see, okay. Oh, did it go? Did you do, that was yours, yeah, that's cool. Yeah, that was it.
yeah, it does. Okay, so it was just that USB that was.
Huh.
Okay, so you have a green laser if you need it,
fun.
and you have just your
Okay.
advancing.
Great.
Or you could use
Yeah.
either of those should.
Fantastic. And then I think this might be her phone.
The live streaming is amazing. Yeah, I tested it.
Is this yours? An awesome job. This is really good. I'm Sam Noll. I'm actually a disaster fellow at GW through like the adult emergency. Yeah, because I heard you were interested in disaster preparedness and like obviously like one of my mentors when she's not busy.
Not busy.
Yeah.
22 people.
I've been watching your lecture. Yeah, 22 people were on her. So.
That's fantastic.
Like it.
Yeah. Thank you.
It's amazing. It's great.
And I was just like, I'm so sorry for texting you at like 7 p.m. because work, like you're just busy and you're like, oh wait, 12 hours from now, something to do. But of course she got again. She was like texting me late, sending me emails late. I'm like, oh no.
Who does that?
Yeah.
Yeah, sorry. I can stuff too. And I didn't even know that I didn't even connect that. I actually knew you.
Well, I didn't either, because I was just that day or no?
Yeah.
And the fact that
It was
you were
fun though.
Yeah.
I'm glad I did it. It's so tough to get away for a full day, but
half a mile or longer just from a metro. Like that was interesting. There's no parking, and I'm like,
start to
yeah. Yeah. Yeah.
So it's gonna have to be.
Yeah. And that's why I hope that translating my hospital to pre-hospital and then just emphasizing the big ideas. And I think it'll complement well with like a lot of these skill stations later today. So that would be nice. No, this is awesome.
All right, we are going to start back. So if everybody could find your seats. Sean, we're good to start the next one? You're all set, right? Great. We got to go from where to. All right. So moving right along, our next speaker for Triage and Hospital Handoff following a mass casualty incident is Dr. Samantha Noll. She is a disaster and operational medicine fellow at George Washington University, and we welcome her today. Thank you for coming.
Thank you. Good morning, everyone. As she stated, I'm Samantha Noll. Hopefully, you'll be able to get a lot out of this, and I value the opportunity to even share and present with you guys today. Of course, to start with disclosures, I have none. So the objectives of this presentation today will include discussing the SALT triage system as well as identifying pre-hospital life-saving interventions related to the SALT triage system. I will also address EMS communications with receiving hospitals and then throughout the presentation discuss pediatric considerations. So let's just start out by discussing the definition for mass casualty incidents. In a very broad, general definition, it's any kind of incident in which the number of patients or victims overwhelm local resources. This will focus more on an incident occurring over a rapid period of time. However, it could be static, meaning one event occurred and then we're kind of moving forward from there, or a dynamic where it could be an ongoing process. However, as I know with some of your protocols, different jurisdictions have varying definitions of what institutes an MCI, which I'll be using that term. It may be a number thing where a certain amount of people will trigger an MCI, or the situation itself may trigger an MCI based on the resources that are needed. Another thing just to discuss of the kind of situations that could go under an MCI. I know a lot of us think of traumatic incidents as well as intentional, but let's not forget unintentional can occur as well. Unfortunately, you know, in the US we're dealing with mass shootings. There's always the fear of a terrorist attack or an intentional sea-burn event, but definitely unintentional, any kind of blast, structural collapse, multi-vehicle, motor vehicle collisions, as well as water accidents and drownings, and then even consider weather or temperature extremes, maybe during a mass gathering, could all be potential MCIs. So let's have this scenario. You know, it's the early morning, it's on one of the interstates, and you're one of the first on scene after a state patrolman called in with the concerns of a bus rollover. You are told that there were some kids that were ejected from the bus, there are some that are still trapped inside, and there are some just kind of wandering dazed. How do you start? What do you do? You're just on scene. Any ideas? I know you guys have ideas. Shout them out. Back up, all right. What else? Additional resources, sure. Okay.
Try to transport the walking wounded away from the scene.
Sure, absolutely. So I think there are definitely a lot of priorities there. Scene safety and kind of sizing up and getting situational awareness is going to be as soon as you step up or even drive up to it, you'll be doing that. And when I say scene safety, yourself as well as mentioned the people involved in the incident as well. At that point in time, resource request, backup, you're talking to other people. You might be establishing the incident command or initiating a unified command at this time. And then how do I access these patients? Is this an active threat? Am I going to be activating a rescue task force? And once you access the patients, again, what I'm mostly going to focus on this discussion today is triage, transport, as well as treatment. And then, of course, ideally, in any kind of MCI or any kind of event, you're handling adequate and appropriate communication. So triage, again, that's kind of what I'm focusing on today. Many definitions of triage, and the idea is that you're doing the greatest good for the greatest number. And I know there's a lot of ethical considerations there that I'm not going to delve in today. But I think a big part of triage is to recognize your limitations and also your resources. So I'm just going to start right away and jump into Jumpstart Triage. I know that there are still systems that use this triage method specifically for pediatrics. And this was developed in 1995 to parallel START triage system for adults. And it focuses, again, on specific values for pediatrics based on respiratory rate and also using the AVPU and then using rescue breaths as well. And again, this triage system has been very successful. A lot of people are very comfortable with it. However, group consensus in the late 2000s felt, this is okay, and there's many other triage systems and algorithms, protocols, but the question is, can we do better? And so a group of national entities from pre-hospital, in-hospital, pediatrics, adults, everyone kind of came together and figured out, or tried to figure out, is there a way to kind of simplify this and standardize it based on the data we have, the information we have, and the feedback from multiple agencies. And so the model uniform core criteria for mass casualty triage was initially came out in 2008, but was more finalized in 2011. And this focused on, okay, we're going to try not to just choose one specific triage system. What we're going to focus on is a triage system that works best for the jurisdiction or the local entity, but we have a few guidelines that we're going to recommend no matter what you choose to use. And this kind of triage system that they're proposing should be simple and easy to remember. You don't want to be looking at a back of a card to remember, oh gosh, what's the rest or what's the blood pressure I have to worry about? And can I apply this to any situation, any person as well? And again, these are triage systems for mass casualty when you're already in a difficult and kind of challenging situation. And can I apply this in an austere environment where I may have limited resources, or it may not even be a safe place to start working as well? And then other things that they kind of emphasize are you should still try to identify and kind of mark triage patients, and then they do recognize that this is a dynamic process. Both the scene itself can be dynamic, or kind of the ongoing environment can change as well, and they know that people can get sick or get better along the way, along the timing. So they still recommend an assault triage system. This is endorsed by, again, multiple agencies, and it's a very broad and general triage system. They use the term SALT for sort, assess, life-saving interventions, and then triage/treatment. And so as you can see here, which we'll kind of go into, so hopefully it'll be a little more visible throughout the way, you have step 1 and you have step 2. Now step 2 does kind of a two-part process, which we'll go into, but again, this is just supposed to simplify as much as possible so that when you are in charge and you are on scene, hopefully you can make this as simple as possible, which of course there's a huge asterisk with the term simple. So I spent all my training and time focusing on Jumpstart. What about new SALT? does it work? How do I know? Well, there have been a handful of studies that have been done both in simulated sessions as well as real life to see what is more applicable. Fortunately, there's both the SALT and Jumpstart for pediatrics has shown that it has similar accuracy based on appropriately tagging a person, as well as similar outcomes in both under and over triage, because every triage system knows you're going to either under triage or over triage just based on the limited information, the limited assessment that you do. And then as well, they both take a similar time to perform, which is just around 30 seconds. So you're still getting what you need to out of both of these triage protocols, especially with the pediatric population. One thing that came up in multiple studies is when you're in the field, when you're performing this quick triage and then deciding who we're going to transport, who we can treat, what resources we have, just being able to establish who's immediate and who's dead actually was very critical, because it really affects what resources you have and who sadly you can save and who you can't. So let's talk about the first step here, global sorting. So with global sorting, again, this is step one. The idea is to prioritize victims for individual assessment. So you are really just trying to divide up a large group of people. And in this case, you're using just simple commands. Ideally, just asking those who can walk, get up and walk. And then everyone else, you're just quickly saying, thumbs up, can you wave, things like that. And I'll kind of go into that in just a second. So the first priority in step one is trying to identify who needs a life-saving intervention. So these are people who are either or have no purposeful movements, as well as you see a life-threatening injury to that person, more than likely a visible hemorrhage or some kind of life-threatening injury as well, just by looking at them. The next priority is identifying those who are unable to follow the command to ambulate. So they may be non-ambulatory due to an injury or something else, but you notice that they can still follow other commands and/or they have purposeful movement. So you might be able to have someone giving you a thumbs up, or they're wiggling their toes or something like that, but they just can't get up to walk. The third priority, again in step one in global sorting, is identifying those who can follow commands and can ambulate. As seen here, ideally they can ambulate to a designated area. These people can follow purposeful commands and they have no obvious life-threatening injuries. And of course, that's where it gets a little complicated, which we'll discuss in just a moment. So as you can imagine with global sorting, because again, this is just quick, this is visual and just speaking with simple commands, there's a lot of pitfalls. What if someone has some kind of blast injury, they blow out their tympanic membranes, they can't hear? What if they don't speak English and you're only speaking English? What if they're confused and dazed from a head injury or something else going on? What about children who are all alone and terrified? They may not follow any commands. Or what if a child is severely injured but is being held by or a guardian or someone else who's not injured, so takes them over to the green area or takes them over to the safe area? And then what about the people who can ambulate but, lost half an arm? Unfortunately, it's not a perfect system. And again, the idea is that we're doing the greatest good for the greatest number. So pediatric considerations during global sorting. Again, using colored tarps for assigned areas may be more helpful because, again, if they know to go to the green, maybe they'll see it as a game and go to the green tarp. Other things you can maybe potentially do if you have the time and or resources is to designate a pediatric safe area. In this case, you are identifying maybe kids that don't look injured at all, you'll eventually need to reassess, but you can place them over as well as in that area, it could be an easy space for family reunification for those that get separated, as well as it could be a spot where they may not have overt organic medical needs, but you're reassuring them, you're talking to them, like that, just to keep them engaged, keeping them from wandering off and things like that. So with the next steps, I'm going to focus on, again, here you can see in the step 2 under individual assessment, we're going to focus on life-saving interventions. As you can see, this occurs between the other part of the individual assessments. So, life-saving interventions. These should be performed prior to assigning a triage category. So this is when you're looking at the people and you think, I might be able to do a life-saving intervention, which I'll kind of discuss a little further. These life-saving interventions, there's a few things that the MUCC, as previously mentioned, have really emphasized. You are performing these LSIs when the equipment is readily available. You're not searching for it, you're not asking for it. It is within your scope of practice, which again, most of these LSIs are done with things like pre-hospital trauma life support, maybe with BLS or ACLS training you may have already have experience, and so they feel it's within the scope of practice for the pre-hospital provider. You should be able to perform these quickly, within less than a minute. You aren't going to be dosing things or anything like that or doing very technical interventions. It's going to be quick. And then these interventions do not require you to stay with the patient. So keeping that in mind, that these are things that are quick and potentially save a life. So these are the 4 life-saving interventions that are emphasized. Hemorrhage control, adjusting the airway, chest decompression, and the use of antidote auto-injectors. So as you can imagine, this does not apply to every single person, but this can be appropriate in certain settings, in certain contexts. So let's start with controlling hemorrhage. And this is ideally considering Stop the Bleed campaign. In this case, you see an obvious external hemorrhage that's concerning to be life-threatening. In extremities, it's applying tourniquets. In areas like the neck, the head, maybe the abdomen, you're applying direct pressure. Again, these are things that are quick, and these will be discussed a little bit more this afternoon, but I just want to give a few notes about this, is the use of tourniquets. Again, in the scenario where you feel a tourniquet would be appropriate and you have a pediatric patient, it is okay to use commercially available tourniquets. They may appear to be adult tourniquets, but studies have shown both in the battlefield with pediatric casualties as well as unfortunately recent shootings and as well as in other studies that have been performed that you can use the CAT, you can use the softy tourniquets on a pediatric patient, and you're doing the exact same approach. You are applying it proximally and you are going to tighten it until you lose that distal pulse, and you're going to do the same thing as you would an adult, that if you still have that distal pulse after you felt you have tightened it or it's still bleeding, you apply that second tourniquet just like you would in an adult. I can't emphasize that enough. I know it gets wary because, and I know there are pediatric tourniquets out there, but go ahead and use an adult tourniquet. Applying direct pressure or hemostatic agents, again, this is used probably more in a place where you can't place a tourniquet. You're not putting a tourniquet on a neck. This might be the spot where you're going to use direct pressure or hemostatic agent. Keeping that in mind. Other life-saving interventions, opening the airway. Again, you have an apneic child or obviously an apneic adult, you can do very basic maneuvers. You do not need to intubate or anything like that because again, this should be a quick intervention taking less than a minute, and you should have the equipment readily available. So in the right people, and including the pediatric population, you might do the head tilt chin lift as seen up here, or the jaw thrust seen here. And the idea is that, again, you're trying to open the airway to help with any kind of obstruction or anything else. I believe we'll be going a little bit more into pediatric airways this afternoon, so I'm not going to go into the differences of pediatric airways, but just keeping that in mind. However, they feel that, it is known that apnea and hypoxic events have caused a significant amount of, again, more focused on the respiratory complications. And that's why in the pediatric population, during this time as a life-saving intervention, you can give just 2 rescue breaths. You don't need to give 5, just give 2. Another life-saving intervention, chest decompression is the term they use. However, you may know it as needle decompression or needle thoracostomy. This is in the patient that is obviously showing respiratory distress, and you may see some form of a torso injury. And again, you're thinking, Do they have a tension pneumothorax? Is this something I can quickly try to intervene on? And so that's why there's the recommendation of this needle decompression. Again, it may be very difficult to look for things like trachea deviation and things like that, and you will not have a stethoscope to listen for breath sounds. So again, this is that person that you see with respiratory distress and some kind of torso injury or on the back as well, that you can perform a needle thoracostomy, which is the proper term of just saying needle decompression. In this case, in the pediatric population, which I have here, you can use an 18 gauge or larger catheter. So 18, 16, or 14 you can use when you're placing it. You're going to place it again in the second intercostal space at the mid clavicle, ideally just lateral of the line of the nipple, and then you can just use a standard length catheter. You do not need to use a longer tip catheter as you would an adult. Just a standard catheter would work. Studies have shown that, and so that's kind of nice that you have almost essentially more potential options versus adults. Furthermore, I would have you consider in the appropriate patient chest seals. So maybe someone with respiratory distress and an open chest wound or a sucking chest wound, if you can visually or hear that right away, you may consider just some kind of an occlusive dressing in the setting, because again, it's quick, you may have the equipment readily available, and you do not need to stay with the patient acutely when you place it. Antidote auto-injectors. So this is another special scenario when you are concerned for nerve agent exposure or some kind of organophosphate exposure. So again, this could be intentional with some kind of, gas attack or some kind of explosion or some kind of chemical spill or something else where you're concerned that there's exposure. And in this case, it is okay to use the standard duodote or Mark 1 kits. Now again, both of these kits have two different medicines. You have atropine and pralidoxime, or also known as 2-PAM. And both of these have the adult standard dose, the 2 milligrams of atropine and the 600 milligrams of 2-PAM. In the pediatric patient, no matter the age, if you go ahead and get it. The picture here is taken off the Mark 1 kit. Again, ideally in the lateral thigh is where you'll be injecting these kits. And keep in mind, depending on what you've practiced, the duodote only has one injection, and then the Mark 1 kit actually has 2 different injections that you would have to do. So again, whatever you're familiar with. There are chem packs that have different dosages of atropine injectors, auto injectors as well. If you have those available, I would say go ahead and follow this protocol. But again, this is one of those, you likely have this in your bag, this is quick, and this is before the release of chem packs, and so that's why it's more likely that you would have this readily available. Now, to discuss in my pediatric patient, what's a sign of severe symptoms of, again, some kind of organophosphate toxicity or nerve agent toxicity. The severe symptoms, because I think we're all familiar with the sludge and that god-awful picture of that man sitting on the toilet, very uncomfortable, which I did not bring today because I think you hopefully have seen it before in other bioterrorism lectures. But you'll see extreme sludge, you'll see that extreme salivation, a lot of secretions, eyes watering, eyes red, urinary incontinence, multiple GI losses both from above and down below, very loud bowel sounds that you may be able to hear even without a stethoscope, of course. But the most severe and most concerning are severe respiratory distress, cyanosis, they're blue, as well as seizures or convulsions, as well as bronchorrhea and bronchospasm, and then bradycardia. Again, these are the severe symptoms you would see when you are concerned enough. Go ahead and place that auto-injector no matter the pediatric age. So, yes?
So those severe symptoms would be accompanied with this sludge?
Likely, and now it could be depending on what time you see, like at what point of time you see this patient or victim, they may be kind of developed down here. In the most ideal setting, you may see this. And again, you may see multiple people with very similar symptoms as well to urge you to go ahead and do this. Good question. So the next steps, again, we're still in step 2, is going to be the individual assessment. And so we'll try to go through this. And again, any questions, please feel free to interrupt me. I may not see you, so go ahead and speak out loud. So each victim should be assigned one of 5 categories, as you can see here. I think we're all very familiar with the immediate, delayed, minimal, and dead, but there's also the expectant, which I'll discuss. So when you're doing the individual assessment for each person, so you've already sorted the patient, you've already attempted to figure out who needs a life-saving intervention and who's had that life-saving intervention. At this point in time, you're assessing each individual. The team who, as I mentioned, created these standards feel that assessment itself should not require specific counting or timing of vital signs. So you don't need to be counting the pulse, counting respirations. It does not require diagnostic equipment, so you do not need that sphygmomanometer. You do not need to be checking blood pressure. And when you're looking at overall perfusion, do not rely just on capillary refill. Use quick, physical assessments to do that. So let's start with who would be ended up being assessing as dead. These are the people where you first are looking. Are they breathing or not breathing? And this is where they're not breathing, and after those simple airway maneuvers, and in the peds, 2 rescue breaths, they're still not breathing, they're marked dead, black. So what about the people who are breathing? That's where we get, we branch off into further down the algorithm. For those who are immediate, any of the following, if they are unable to follow commands or have no purposeful movements, or they have no peripheral, or they are in obvious respiratory distress, or they still have a life-threatening external hemorrhage, meaning an uncontrolled hemorrhage even after doing that life-saving intervention, and you feel though they are likely to survive based on available resources and timing, they are marked immediate or red, which I'll kind of go into prioritize. As you can see, very similar to immediate, where they're unable to follow commands or no purposeful movements or no peripheral pulse. They're in obvious respiratory distress, and again, and or they have uncontrolled hemorrhaging, but you feel they are unlikely to survive with available resources. They're marked expectant, which is gray. Delayed. So again, these are people that are breathing, and they should be able to follow commands and have purposeful movements. They should have a peripheral pulse. They should not be in respiratory distress. They should not have an uncontrolled hemorrhage, and their injuries are significant enough, then these are marked delayed or tagged as delayed. And so again, going back to expectant immediate, if you have any of these conditions, just even one of them, they're either going to be marked immediate or expectant. So then to the algorithm for delayed, where they should have all of these conditions and they have a decent injury. I wouldn't consider it minor. And that's where it comes up to your kind of subjective assessment. Minimal. So again, very similar to how considered minor based on your assessment. Why is all this important? Why are they marked with colors besides the fact we like our primary colors and everything else, and we like the color green because it makes us happy, means go. It's because we're trying to prioritize quickly what we're doing for these people. We're trying to focus on who needs treatment right away, who needs to be transported right away, how do we organize our resources to get these things done. And so that's why, based on that triage and that categorization, this is the recommended order of treatment and transport. So again, immediate, because of the fact that delayed means, as we mentioned, kind of they have pretty significant injuries. Minimal is the fact that, again, they likely have minor injuries and eventually will need care. And unfortunately, expectant is you're just that we just don't have the resources, don't have the time to keep them alive. And so with expectant, it's really, if you have the resources to do it, you have the transport availability, you've taken care of or gotten off the field all of these other people, that you can go ahead and obviously work on the expectant victims. So quick things about patient identification. Tags they can be useful, as you can imagine. Specifically for the pediatric population, they can be very useful, but you may have to get creative and look for obvious birthmarks or scars in the nonverbal patients or pediatric patients, and then also the people that are unable to offer any demographic information. In kids, you may try to find out, what are your parents' names? What are your siblings' names? What street do you live on? What are your pets' names? What age or grade are you in? Just so that you can offer some kind of accountability with your tags, which again, I'm not endorsing any specific tag. Whatever works with the agency you're with, go ahead and use, just be familiar with it. And I'll note one other thing. The reason why tagging or marking can be so crucial is for reunification. Depending on where people are transported and everything else, it can be very useful. You can use tape and just write permanent marker and tape. You can do that. And again, there's a lot to, if you'll see, and I'll show you on the next slide, there can be a lot to fill out. And I think tag especially identifies some of the pitfalls where you may not have time to tag someone. You may just be scoop and run, literally, depending on the situation, depending on the scenario, depending on your judgment, as well as the fact that they can be complicated and time-consuming too, or you might mismark them. That's understood given the circumstances. As well as the fact of you may have multiple tarps in different colors, but you may not want to be moving around very sick, critically injured people, especially if we can't even immobilize them yet because we don't have the resources for, then you get in trouble because you may be falsely reassured that they're, already happy in the green section. Other considerations during a mass casualty incident that definitely can vary on the scenario based on what's going on, the timing, as well as your own protocols, could be whether or not you're going to set up casualty collection points. Is decontamination required based on what the possible exposure or incident is? Do you have the resources to provide on-scene treatment? And if so, are you performing secondary triage? And are you going to use the same, what protocols are you going to use for secondary triage? As well as, where am I transporting? Which I know that there's going to be a lot of communication with dispatch. You're going to follow protocols, and there's sometimes where you won't be following protocols depending on the incident. So a few anatomical pediatric considerations just to discuss. Again, I think this will be discussed kind of later on in the day depending on the anatomy. Talked about, especially in mass casualty incidents when we're concerned about trauma. A lot of pediatrics, and the smaller the size, they may have the larger head proportion, which may make them more prone to head injuries. The same way they have a larger body surface area, that they're definitely more prone to hypothermia than the adults. I use the term fluid, but they have a less fluid reserve that may make them more prone to hemorrhagic shock in the sense of bleeding, maybe hypovolemia if they are having GI losses, and dehydration as well compared to the adult. As well as they may have more compensation in early shock where they may just be only mildly tachycardic, but however, they could crump very quickly. And so keeping that in mind just to terrify you more further, but to also let you know that reassessments can be very critical, especially in the pediatric population. Other pediatric concerns to consider is the fact that they do have less respiratory reserve. So although they're tachypnic, they may crump quickly because they just don't have that reserve, and they don't have the muscles as well to kind of handle any kind of respiratory distress. They also may be more prone to multiple organ injury for multiple reasons. For one, they actually have poor rib protection that can affect the upper organs and the lungs more compared to as well as they have less mass, and so depending on force and blast injuries, which may be discussed later today, they could put them at more risk and have more injuries compared to the adult despite being exposed to the same blast injury. They have a more mobile mediastinum, which means if they have a tension pneumothorax, it's capable to cause for them to decompensate quicker and decrease their cardiac output quicker in the setting of a tension pneumothorax, as well as the fact that they're small and they're close to the ground, so they may be easily exposed to a toxin or a gas that lies more commonly on the ground, as well as the fact that they have larger minute ventilation, which means they may be more prone to inhale more aerosolized agents in the case of some kind of biologic or toxin release. And so I'm going to make another note on that with contamination in the pediatric population. Again, in the right scenario where you may have to do pre-hospital decontamination, just a few other things that I just want to emphasize is the fact that all pediatrics are at risk for hypothermia more than the adult. So keeping that in mind, the water temperature, of course, as well as being able to cover them quickly and clothe them quickly after decontamination. Other things specific to age groups, infants and toddlers, they can be slippery. So you may actually consider putting them in some kind of like basket with holes, things that won't allow them to drown when you're decontaminating them. It's true though, because you do not want to be the person who drops the baby. You're not faking that seizure. Otherwise, they also can't cooperate. It could be very difficult, even if they are with their parents. Preschoolers may throw tantrums forward. Families should stay with them and assist with washing, but they should not be the sole person to wash them. There should be some kind of provider who's actually experienced with it. As well as school-age children may refuse to disrobe in public, so focusing on that need for curtains and barriers, keeping that in mind, and still having potential gender separation as they're older. Younger pediatrics don't necessarily need that gender separation. So a few things to note on transport. Again, a lot of this will be based on your local protocols. You're going to be talking to dispatch a lot because when you're triggering that mass casualty incident and that notivation, it's ideally activating the whole area response, both with resources as well as discussing with hospitals capacity and things like that. That shouldn't necessarily be your role, but you should be working with definitely dispatch as well as possible other EMS agencies that are supporting the incident. You may be discussing with law enforcement depending on the needs for transport or if there's security measures that need to be undergoing both at the scene and then en route to the hospital. And then there are those instances where you are talking to the hospital directly as well to either find out appropriate direction of where you're going, or as well as just reporting what's going on with the person you're transporting. Other things to note, again, this is based on the national criteria that they do recommend pediatrics less than 8 years old should go to a pediatric trauma center, just because that age and younger has more specific needs that would be best maintained at the pediatric trauma center. However, it should very much be considered to keep parents and children together and not separate them, even at transport, and keeping in mind that the family member with the most critical injuries would likely determine the destination as to where they're going. And so that's why in this picture here, you can see mom in the back in the ambulance as well. Other things to consider in transport, again, you're in a vehicle that you're ideally comfortable with working, you know what equipment you have. That's when you're going to focus probably more on the related injuries and figure out what you can do while you're en route to the hospital. Again, depending on the injury, the mechanism at this time, you can hopefully focus on spine immobilization that you may not have been able to do in the field. Again, given the fact that you're trying to just triage as many people as you can and provide the greatest good you can, that again, it may be very difficult to maintain spine immobilization in the field, but once you're in your truck or your vehicle, you should be able to consider that. Further hemorrhage control, you may have a tourniquet placed, you may have something in your truck to place that second tourniquet that you didn't have before, or you might be able to apply direct pressure as well, or you may have hemostatic agents as well that you can definitely use. Here, this is just a clamshell technique for applying direct pressure to a wound, given it's near the joint that it may be more difficult for a tourniquet to be used. Other things you can do is reassess whatever maneuvers that were done in the field, reassessing those tourniquets, reassessing any dressings, chest seals as well, and again, focusing on those airway maneuvers and those devices you may have. Suctioning can be so important, proper, again, airway openings, the use of adjuncts like nasopharyngeal or oral airways, as well as the fact simple things like bagging. You don't necessarily have to intubate, you do what you're comfortable with, and bagging can go very, very far in addition to just regular supplemental oxygen in this scenario, specifically with the pediatric population. And a big, big thing that we can't emphasize enough is preventing hypothermia. I know in that other picture there, this patient is just fully exposed. Still keep them covered, try to reduce their insensible losses and try to prevent any coagulopathy and things like that. And finally, something you can do, offer reassurance. In tell the patient or victim, you're safe, you're in a safe spot. Tell them what you're doing to kind of hopefully open up that communication, because they are probably in that traumatic event, and in that setting where this is kind of playing a role of possibly having issues in the future with, being traumatized to the scenario and the event that they just experienced. So communication, handoff is necessary at the hospital, even with high volumes. Even if you feel like you have your situation under control, you might be transporting a patient to the hospital that's already overwhelmed. Employees are busy. There are people doing multiple things with multiple different people. And of course, as you know, besides just that triage tag, you need to do that handoff. And some of the reasons to consider of why you want to voice it in addition to just kind of what might be your standard handoff, is the fact that, of course, as I mentioned before, the tags may be falsely reassuring. They may have decompensated or deteriorated during transport, and if you don't emphasize that, someone might just see it green and say, hey, I don't need to worry about that. As well as equipment concerns, in the sense that you may do a great job with hypothermia and have them covered. Someone doesn't know that you have a tourniquet on the leg, or they may not know that you have an occlusive dressing on, or things like that. So you're not only going to voice what you've done to them, but also failures. You may have placed an IV en route. You're concerned that it may have infiltrated or it's not working, so that they don't rely on it and they know to place it even in those dire measures. And so communicating those things as well. Possible exposures, or if you decontaminated them in the field, for them to kind of be aware of what to look for and other signs that they may not necessarily know, and maybe passing along the information of where other family members may have been dispositioned, or if there's concern for an expectant or dead family member, to kind of keep that in mind, as well as any CPS concerns. Again, in a multi-vehicle collision and their children not in the appropriate seats, you may have to pass that along, because that's something that you don't want to lose, despite the large volumes and kind of the overwhelmed resources. So to summarize, mass casualty incidents can be very difficult to manage, as you know, for multiple reasons. The scenario, the numbers of people, as well as kind of the stress, the anxiety, and every agency, unfortunately, has varying protocols. And so I was hoping to emphasize a primary triage that is simple, it's scalable, and it's rapid, and hopefully easy to remember. And then other things to focus on: life-saving interventions in the field during a mass casualty incident should be performed during triage. And ideally, these are rapid interventions within your scope of practice. And as kind of I mentioned, these are okay to perform even on children with the equipment you have. Furthermore, treatment and transport will definitely vary on the situation and the resources, and again, local protocols. And of course, the pediatric or child population definitely has special considerations in mass casualty incidents. Are there any questions? Comments? All right, thank you very much.
just leave it here for now because it's going to continue to.
I hadn't seen you when I was having a panic attack, and I was like, I gotta text Joelle. And Chris was like, she's here. And I was like, right, but if she's in front of her computer and she's doing like a grant or something, you lose track of time. I should text you. He was like, she's in the auditorium today. And I was like, okay.
Yeah, it's been here like 30 minutes.
I was just setting up. That's okay. Thanks a lot, Terry. Thanks a lot, Terry.
So these mics are further around, and then this mic is further around. So you can, if you move away from the podium, just loud enough so that people in the room can hear you. But so it's actually you want me to introduce one liner for everybody else.
They're so common across speakers. It's the same thing. Like people start introducing, it's like.
And you just kind of like want to hide under a seat.
Right.
You're like, just say, my name's Cindy, that's it. I don't need an introduction. Hey, I'm Cindy. I did EMS.
Right. Right, because you're
So
standing.
which one of your job roles do you want me to introduce you by? Which one? Yeah.
Oh, you have to call her the Master of Disaster.
Okay. She is the
Master
okay.
of Disaster.
I'll start by saying that you're
She's the Master of Disaster. Oh, start. They don't care. They don't even know what attending means. They don't know what that means. And they won't care. They will like her if you start out with Master of Disaster.
Master of Disaster.
I don't kind of look.
Extreme participants. Okay, our next speaker is Dr. Joelle Simpson. Joelle is an attending physician in our emergency department at Children's National, and she's also the program director for EMS CDC, and she can tell you a little bit more about herself. She's speaking today on caring for children with special healthcare needs. So welcome.
Thank you. Okay, I am very excited to be here. I usually give talks that I've given multiple times. This is actually the first time I'm doing this particular talk. Personally, for me, one of my, main hats that I wear here is to run the Emergency Medical Services for Children's program. And for those of you that have not heard about that program, I'll tell you a little bit about it. The other hat that I wear is to do a lot of the disaster planning for the hospital as the medical director for emergency preparedness here. So, that can be an overwhelming task, particularly here in DC. While we already talked in some of the earlier presentations about some of the unique features of kids, just your average everyday healthy kid, when you talk about kids that have chronic medical conditions and other needs such as equipment support and so forth, that adds another dimension that can be a bit more tricky to manage, particularly for folks that have not had experience in working with kids with special needs. So I wanted to delve into this topic only because even myself, as a pediatric emergency medicine provider with years of experience, there's still aspects of working with children with special needs that make me uncomfortable because I'm not as aware or familiar, or certainly I'm not as exposed to that type of patient as often as I would like to feel truly comfortable. So what I wanted to do is lay the groundwork that here, that it's okay to speak up and let me know what parts of this things or aspects working with kids that you're not familiar with, because I think that it's important to sort of acknowledge where our gaps are so that we can move forward and figure out the best way to work with these children. So the agenda I'm setting today is to learn about caring for kids with special healthcare needs and the devices that they may come with, and to talk about this in a case-based format where we will discuss the most common pediatric medical hardware. Now, with today's technology, there's so many things out there, but there's some basic tools and even some mnemonics on how to troubleshoot using or assessing hardware and the child at the same time, and also, just to empower our own confidence in caring for patients with special healthcare needs. So first off, it's sort of what does this mean, right? There's been a definition established by the American Academy of Pediatrics since 1998, and every reference I looked at since then saying, well, let's see if this has been updated, is there anything new? But most or the majority just still come back to this 98 definition that children and youth with special healthcare needs are really defined by the fact that they have risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required by children generally. So that could usually lead to the fact that they are children that may have multiple diagnoses. And while there's this exactly caused a condition, many times some of their diagnoses are still sort of unclear in terms of giving a name to a syndrome or condition, and that can have its own element of confusion or ambiguity when we're trying to assess. They also are typically cared for by what we call a medical home, multiple subspecialists that are in fields that I didn't even know you could train towards, right? So these people who've had 10 to 15 years of additional training to work with a specific disability. And so that's also very understand. It would be awesome for us to all have universal sort of medical records and access. That also complicates if we have who has not been seen center and a child arrives on your doorstep. And I'll show you an example in a bit, but they often require additional services that are beyond just health. There may be things like language, other aspects of health that may be causing a core of their issues or add another layer of complexity to their assessment. And then they will often travel or sometimes even nationally. Because we are often an international destination. We'll get children with very complex healthcare needs from all around the country looking for that can take. But certainly, as I said, they're sort of multi-system issues that if they become sick, we are caring for children where their core primary care or medical home may not be in Washington, D.C., for instance. So this is at least compelling to me. It's a mom that decided, she has a child named Lily. Lily's in the center. And a mom that created what she calls this her care web of all the different bubbles that she touches on almost a daily basis in order to care for Lily. And in terms of the who is currently in the area around the brain and developed a seizure disorder, has asthma, has developmental delays, has reflux, has cerebral palsy, has hip dysplasia, so some coordination limitations. And so very complex, has many multiple specialists, as you can see, gets therapy or physical therapy, has a special nutritionist, has vision needs. In the home environment, needs to have modifications to the home structure. So in terms of you accessing the home or being able to, if the patient calls 911 and being patient in terms of their own their own disabilities. Mom also navigates insurance coverage and just things for the child's well-being. So attending school, doing recreational events, all takes into account a sort of an additional layer on top of what you would expect with a healthy, uncomplicated child without as many medical conditions. So the equipment associated with children with complex healthcare needs can be anything. If we go to our ABCDEs, tracheostomy tubes, you guys are familiar a lot with CPAPs, especially in the adult population, using home ventilators, central venous lines, VP shunts, which I'll talk a little bit more about, and then potentially even things like central access or central intravenous catheters. Just by a raise of hands, how many of you would say that on a weekly basis you take care of a child that may have one of these devices or complex medical conditions? Weekly? Okay. How about monthly? How about maybe you'll see one of these a few less than 5 a year? Okay, and that's the majority, correct. So we'll go through some of the most common types of equipment and troubleshooting that. But I want to really focus on the fact that this is really not to overwhelm or get too bogged down in the details of these complex conditions. Sort of that bird's eye view of the basic assessment way to approach. What the American Pediatrics and even the American trying to encourage on the other end of things, on the family side of things, is to have families completely focus in on getting what we call emergency information for where this standard form is used for the family to be able to share the most up-to-date information they have on their child. So when you are coming to the house, to be sort of a communication about all the different aspects of your condition. And this is important, especially because, of course, going to be with their child 24/7. So the idea is that this form stays with the kid no matter where they are. If they are at school, if they're with a nurse that's caring for them at home. And there's a push certainly for this to become more electronic, so it would be on devices and apps. And I believe there's some apps coming out for families to have this. Certainly, even if you make a visit and you have a child that you see regularly or who gets called, EMS gets called to the home, and this has been an issue in terms of conveying the information and the most up-to-date clinical condition of the children, it's really important for all of us that touch these kids in the healthcare field to encourage upon the family sort of the development of a within the whole realm of kids with special needs. I think the natural inclination is to go to kids that development, motor disabilities, etc. But the whole autism spectrum disorders realm is something that many of you, as you may hear just in sort of published report has been increasing in numbers, and there's some debate about whether it's increasing because there's sort of more refined diagnostic abilities, or there are sort of redefinitions of what autism is, which is now sort of highlighting higher numbers of patients, or truly there might be an increase in autism in general. That's not going to be the point of our discussion today, but certainly that adds another layer of different ways to approach children. And it's sort of the take-home message with autistic patients that are in terms of how they communicate with strangers. So deferring, and often what we would do in at least my practice, is to even have the family member or guardian help with doing the exam, or with sort of helping me, walk me through what their actual concerns are, to focus on eliciting what the chief complaint truly is due to. So you guys are very familiar with the assessment triangle, pediatric assessment triangle. We think about a parent's work of breathing and circulation. That's what we do for every patient that we see. Getting baseline vital signs and what behaviors are going on that might be different from the norm that are concerned about, but also establishing those major medical issues. The things that you want to focus on asking the parents about can be obvious, but really with kids with special needs, you want to ask, what are the previous problems? Is this a child who goes to the hospital frequently for a particular type of reason, either related to their equipment, for instance? What backup devices do you tend to have? For most of our subspecialty patients that have any device that is a removable device here, so meaning a trach or a G-tube, 99% of the time they're discharged with a backup device. So if something gets dislodged, they usually have something at the home to replace or to mitigate until you bring them back to the ER to their subspecialist. Very important, particularly for the children that have ventilators, is getting the most recent settings or pressures that are on those devices, the emergency information form, like I mentioned before, and then what are the communication tools that are used? Many kids nowadays use, for instance, iPads, or there might be other adjuncts that the family uses in order to communicate with them to help you with your job in assessing. Let's go through a case. This is a case with a 911 call of a kid that says, originally on dispatch, there's a 2-year-old with respiratory distress. Then the update comes that this is actually a 2-year-old with cerebral palsy, tracheostomy, and G-tube in place, vomiting now, and difficulty breathing. What about anything in this update are sort of keywords that raises some concern and changes the way you might ordinarily prep in going to a home? Any thoughts? Sorry? Okay, so the tracheostomy, yes. What else? Difficulty breathing, okay. So the issues you anticipate, let's start first in the row. So cerebral palsy, what is that?
It's like a conduction issue just due to maybe general brain damage or even brain damage.
Yeah.
So it can cause some things like any brain damage, delay or body function.
Very correct. So usually a group of disorders that limits a person's ability to move and to maintain balance and posture, often cerebral being in the name, due to some sort of potential brain injury, and what you see is often spasticity, so tightness of the muscles. Sometimes they might have some uncontrollable movements or tremors, and they may have poor balance and poor coordination, or what's called ataxia. And when we talk about a child with these series of conditions that has respiratory distress, why would cerebral palsy be something that would indicate a concern? What about cerebral palsy might make your respiratory distress chief complaint ring alarm? Right, stiff muscles. So compliance, that should already raise somewhat of a flag. So respiratory distress, and you mentioned tracheostomy. All right, excellent. So some of the pros about having a trach. Great, we have an airway. I know when you're coming into the ER and you tell me it's a kid with a trach, there's something there, there's a track that I can at least deal with. is, what if the actual trach site there's a problem? So what are some first steps you do to troubleshoot a trach? Excellent, suction, for sure. So here's just a little bit of a diagram of what a pediatric trach looks like. You have often the single cannula, which is the trach, the actual trach that goes into the neck. Often, to place the trach in an obturator or this sort of, I call it like a stent for the trach will be placed. It's really important to ensure that that's removed when you're starting to use the trach. And for children, of course, it's very important to have secure ties, et cetera, because they're so mobile, it can easily be dislodged. The challenge for suctioning, as we talked about, is the fact that everything about kids is often smaller, so everything gets plugged easier, and things in secretions especially can get drier and cause obstruction much, much easier than it can in sort of maybe a bigger lumen cannula that you would see in a. So I go through this mnemonic similar to what you do if somebody have hypoxia, when I just placed a tube and we're trying to get effective ventilation. So similar for a trach, there are sort of a quick troubleshooting points you could look to see why is this trach failing. So, or why is this child with potentially with a secure airway having some issues with respiratory distress. So it could be that the trach is dislodged, so that's my D. It could be that it's obstructed, like we talked about. An obstruction from secretions, actually for me, I feel like, okay, that's manageable. Put a little saline down there, do some suctioning. But obstruction from what obstruction in a trach? Swelling. And where would swelling can come just from the disease process, correct? What other things would be concerning? Bleeding. Yes, absolutely. Particularly around trach sites, especially for children that had just had a recently placed trach, there could be scar tissue that once it's starting to heal could start to obstruct the trach site and become evident after the child has gone home from the hospital. And sometimes what we often could see is that there might be scar tissue that now that the kid is home and more mobile than they were in the hospital post-surgery for getting the trach placed, they have now dislodged scar tissue and causing some active bleeding that could be obstructing the trach. And that is a little bit more difficult, or sometimes a lot more difficult to manage because of the complications of sort of managing blood and losing visibility because of that. In a post-intubation dope pneumonic, typically the P is for pneumothorax causing problems after an intubation. For me, I changed it here to call it pulmonary problems. So is there something inherent to the lungs on this kid in terms of potentially a pneumonia, fluid buildup for whatever reason that's causing difficulties for breathing? And then truly equipment malfunction. So is the trach hooked up to a ventilator that's giving you some problems? Is there a cracked part or is the obturator still in the trach that somebody who is unaware left in? Sort of very simple things to troubleshoot to see what could be causing a problem. What I've seen most frequently coming into our ER when it's related to a trach problem has been situations with infection. So tracheitis is a common thing we diagnose here, which is sort of local. Imagine this is something that is getting manipulated fairly often, and these are kids that are sometimes at high risk for developing infections just because of their underlying medical condition. So fevers and then the subsequent increased buildup in secretions can lead to a lot of these problems. So dislodgement or leak, sometimes due to an inexperienced or new caretaker that is taking care of them, that may not be aware of, and as you guys may know, sometimes there is a balloon at the distal tip of the trach site. So there's some children where there may be a leak because the balloon is not inflated. Now, I will say when we've talked to our ENT providers, they will often say, we've placed a trach in this patient with a balloon, but we actually place it there not necessarily to inflate the balloon, but to have the balloon there in case of an emergency when there is a trach that is cuffed, but typically the cuff stays down. So those are small nuances that are hopefully would be on the emergency information form for you, so you have some idea of how to troubleshoot. And then we talked about bleeding, and particularly because there's some critical vessels around where trachs are placed that if they rupture can cause pretty dire outcomes for children. So for this patient, the techniques that we've sort of already talked about is suctioning. You can do bag vask valve into the tracheostomy into the tracheostomy tube. What do you do if the trach is dislodged and you're not able to get a seal on the trach site? What's your technique? What do your next step? You could do a pediatric mask over the trach site, but let's say it's not getting a good seal because of the anatomy. It's giving you a problem. What else can you do? Exactly. So if your protocols allow it, certainly being able to put a tube into the trach site is a rescue measure, because that's an airway similar to you intubating. That's an airway that you are able to use. I would say also you can, if depending on the anatomy of the kids, sometimes you're able to just do a regular intubation if you need to. Or even if we're just keeping it to bag vask mouth, it's okay to bag mask over the mouth, just making sure that there's a seal over the trach site, because obviously there'll be, that's an ability for some loss of volume. And very often, if you're really not sure what's going on here, that's one of your safer bets, is to just sort of cover the trach site and bag mask valve over the mouth. Providing oxygen, there's the trach, and then if it's within your scope of practice, replacing the majority, if not with an extra trach. They're also in your practice. It is perfectly acceptable to say, hey, who in the household got training on replacing the trach? Can we at least do it to place for the ride to the hospital rather than leaving an open stoma? That is, if there's not bleeding and you sort of looked at the site and assessed that might be a venue that you need for intubation. Yes?
Question online, when would it be appropriate to install the cuff?
So if you're noticing that there is a leak coming through the trach, that might be one thing to sort of troubleshoot. Most of you, I would say, probably don't have very long distance to your pediatric centers. For the reason I pause is because, hopefully, well, at 5 o'clock in DC, it could be 4 to get to. I try to do that run between here and UMC, for instance, and yes, that could take a while. I'm pausing is because what our ENT colleagues tell us as ER docs is leak around the trach. Is that clear?
How about bleeding?
And bleeding, sometimes it can tamponade bleeding as well. Thank you for that leading. Sometimes it can tamponade, or surgeons are not necessarily in-house. So if you're telling me, hey, the kid I'm coming in with a trach that's bleeding, once I inflated the cuff, the bleeding seems to have slowed down a bit, but I'm concerned because he's having a lot of issues, then as soon as I hang up the phone with you, I am calling that ENT surgeon to be at my bedside when you get here as soon as possible. Because there's only so much I can do. I mean, I do tend to think I'm Superwoman on most days, but I am very much limited in my scope of practice in terms of fixing a bleeding trach or a vessel that needs to be cauterized because it's been ruptured. Okay?
Could you put a timeline on which we consider short-term versus long-term for compilation?
So over a day is long-term. Okay. Yeah. Okay. So hopefully you have no patient in your care for longer than a day. Otherwise, we need to do some QA with you. All right. So here's the conclusion of our case. This patient, our 2-year-old, had continued respiratory distress. You got him here to the emergency department. We were able to put him on a ventilator because now his needs were escalating even though normally he's on room air. We saw on a chest x-ray that he had pneumonia. We treated him with antibiotics. We were able to wean him off his support back to his baseline. He was discharged home 4 days later. 9 times out of 10, this is what happens. All the other sort of things we mentioned are things that, we should be aware of to assess in more of the high-risk situations, but the majority of your patients, this is what will happen. Okay? So I didn't talk about the home ventilators in patients necessarily. They scare me, to be quite honest. I find ventilators to be, I'm not a device type of person, so when things alarm, it really can be confusing. So I had to put this into very simple terms, like how to troubleshoot the home ventilator. So the first thing is if there's low pressure, oh, okay, so something is escaping somewhere. There's a leak or something's dislodged. Cool, I got that. Or it's high pressure, so something is probably blocked, so it's occluded in some way, so there's my O. Sometimes there could be pulmonary failure, respiratory distress causing the blockage as well, so that's another reason it could be alarming. Or sometimes it's just the equipment that, knowing me, needs to be, like, it is not plugged right, or something happened with a device, and so that needs to be troubleshooted. And I think remembering that the same DOPE we use just for the trach, you can also use it sort of on the home ventilator as well. The important part here is the same take-home message I mentioned before. Talk to the caregiver. Go ahead and use what we know are ABCs, bag valve mask ventilation. And please, 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 please bring the broken ventilator if you have it there with the patient. It's extremely helpful for us to interrogate those devices to be able to get the last settings, et cetera. While we have awesome medical records, and it's really nice to go through hundreds of charts to find out where the last known documentation of a ventilator setting is, it really is much more helpful to just have it off of the machine when you bring it in, okay? So let's do, I think this somehow, did I go backwards? Oh, yes, okay, sorry, cheat. So we're going back to the same case, the 2-year-old with a respiratory distress. We talked about cerebral palsy, we talked about tracheostomy, and we talked about difficulty breathing. But we also, I noticed that he had a G-tube in place. Now, when we were doing all of our assessments and approaching the house to think about how you're gonna troubleshoot this kid, is there any relevance to having the G-tube in place? What are some things about having the G-tube that you can think, okay, at least that's another device I need to think about? Is there an advantage to having the G-tube in place? He potentially won't aspirate, right, because you can potentially get contents out. You can use this G-tube to your advantage. Sometimes, especially if it's a kid in respiratory distress that you now have to bag, and you're pushing more air into their system, then it's helpful to be able to pull back with a syringe to aspirate air, gastric contents, if there's some distension of the abdomen. You can leave a tape glove over the site, which is often what we will do, and that can lessen the risk of aspiration and lessen the competition of having a distended abdomen on what you're trying to do for supporting the lungs. Just wanted to bring that point in there. And so the most common G-tubes that we'll see are these little buttons here, these Mickey buttons, which are really short little sort of T-shaped devices that puts a balloon to hold it on the inside, and then there's a port on the outside for medications. Or then sometimes you'll get a peg tube, which has sometimes a longer extension on it. And the most common reason, there are a lot of kids that walk around with G-tubes without all the other stuff, the trach and all the other conditions. The most common reason for especially our newborn babies to have a Mickey button or a G-tube is because for some reason, they either mechanically aren't able to take in enough nutritional content, or they need special formulas because of their genetic condition and so forth, or metabolic condition that requires them to have supplemental feeding through a G-tube. So similar to the trachs, the G-tubes are something that, if they get dislodged, are also provided to parents when they're discharged from our specialty services. And you can use the same dope assessment if you're troubleshooting the G-tube part of all of this. So it can be dislodged, it can also be obstructed. There can be concerns if the child's abdomen is quite distended, if there's an associated fever, that there's an infection internally, like there's a perforation from the G-tube causing a peritonitis, or it could be, once again, an equipment malfunction. Because, like I mentioned, most G-tubes are placed in kids that might have some sort of nutritional concern, they can be at risk for things like hypoglycemia, and that can be why they're having some sort of change in alteration in their rest. I believe NDC did say do not remove, do not replace, but please do bring in the old tube if it's available. Like I said, most families go home with a replacement tube. The one sort of insights I'll give you about our perspective from the emergency department here is that we actually have a special algorithm for patients that had a G-tube that was placed 3 months ago versus patients that were placed greater than 3 months ago. And that is the fact that a patient that had G-tube placed less than 3 months old often means that it's what we call a fresh G-tube. So at a higher risk for bleeding because it's not yet fully scarred down and formed a sort of the site of the ostomy where the G-tube is at risk for having some tunneling or tracking or more breakdown than an older site. And so it needs to be troubleshooted often by our surgeons and not just here in the emergency department, because it's at risk for having some greater risk for trauma to the site because it's a fresher G. So having some awareness of that on you, if you say, yeah, this was just placed last month, especially when you're, I know that might be a little bit extra to call in, but that would raise our red flags here to say, oh, okay, we have to be cautious about this G-tube in terms of what we would put back in there to keep it stented open. Let's do another case. Let's do another case. This is a 12-year-old male with a seizure, is the initial dispatch call. The update you get a few minutes later is no longer seizing, doesn't have a disorder, but has a VP shunt for hydrocephalus. What does VP stand for? Typically, if you broke up that word, hydroencephalus, water on the brain, cerebrospinal fluid, or the fluid that bathes the brain, looks like water. So excessive water on the brain or spinal fluid in the brain is not safe. Typically, the most common reason for our infants having hydrocephalus is for some sort of congenital issue. We are doing awesome in medicine in terms of having younger and younger babies being born, but what that means is the vessels and the vasculature in their brain is a lot more delicate, and so at risk for rupture and bleeding, causing scar tissue and then blocking up some of the channels with which the CSF typically drains, or the cerebrospinal fluid typically drains. So they're at increased risk for having the buildup of spinal fluid in their brain that then needs to be shunted, and so a VP shunt might be placed. Some kids may be prone to infections, may have had some genetic conditions that cause them to have hydrocephalus. And then there's some that it's acquired, where similarly infections or tumors, unfortunately, can cause some blockage and require a VP shunt. In our younger kids that have an open fontanelle, so the skull is not yet fully fused, and you can feel that little diamond on the top of their head, typically under a year of age, they may actually show that they have sort of a more prominent occiput or front of their head or overall cerebrum due to the increased swelling from an undiagnosed hydrocephalus. It's impressive to see that once a shunt is placed, they can have sort of a more appropriate looking skull shape and size that's not swollen due to the swelling on the brain. So if you see a kid where you're concerned that the head size seems to be a little bit more prominent, particularly in that forehead aspect, not proportional to the lower part of the face, that might be something you might want to pass on in your information when you're handing them. So VP shunt is really self-explanatory because the word sort of tells you what it's doing. It goes from the ventricles in the brain down to, and shunts it down to the peritoneum. And so all that fluid, excess fluid that's building up in the brain, drains into the peritoneum, and that can then be absorbed and basically put out. So really smart. I don't know who designed that as the first test patient, but glad that they did. It's helped a lot of patients. Here you can see the demonstration of where the increased pressure on the brain, the blue is sort of is in excess. Once a shunt is placed, it can put that down to a more normal size. And what some of the components of a shunt that you may feel, even as you saw in the picture with the kid that showed his scar, is sometimes we'll have a little sort of a valve here. It's a one-way valve that goes down so that it's a one-way direction for the fluid to flow. But you can feel that little valve if it's under pressure or swollen. And sometimes the parents might tell you, yeah, his valve is swollen, and that's a concern that now the shunt may be blocked in terms of troubleshooting. Someone got creative and thought that putting it in the peritoneum wasn't special enough sometimes, and if that gets blocked, you can find other ways to put the shunt. So in a few cases, you'll hear of a VA shunt, where someone actually was a surgeon, actually was able to not put it in the peritoneum, but put it into the usually the right atrium, in order for it to go through the circulation and then be sort of peed out that way. So you'll hear a VA shunt in some patients. There are other folks that have actually I think it's a VG shunt to gallbladder. Basically getting the fluid out of the brain is it's a V something shunt in the brain, then it's getting the fluid out of the brain. So in your assessment, my number one thing here, I would say almost a universal truth for most of the families of these patients that have a VP shunt is they know their kids best. These are not the parents that are disproportionately anxious. I often gauge what I'm concerned about off of what the parents are concerned about. So if the parents say, I'm concerned this is a VP shunt issue, I'm going to believe them and try as best as possible to prove that that's true in whatever ways I can before saying, oh no, mom and dad, you don't know what you're talking about. So typically, this history that I gave you with the case showed that he was having a seizure. It's important to know, I mean, it's easy to assume sometimes, particularly if kids have complex medical conditions, that one might assume, oh, well, seizure disorder is probably part of it. If seizure disorder is not, that can be a concern, particularly in a kid with a VP shunt, that it is an issue with the shunt. If they have no fevers, vomiting, neck pain, head trauma, knowing if they have apneas or irregular breathing, or any recent medication changes is very helpful. What we know about this patient is that he had no seizure disorder, but his VP shunt was just revised 2 months ago. He's a former premature baby in the NICU, now highly functional, but is not on any daily meds. So anything about his medical that even higher risk just for the fact that he has a VP shunt? Anything there? Exactly. So really important to know this was just revised months ago, because as close as possible to any device in a child being manipulated means that now we're seeing signs of infection or signs of this kid is now becoming more and more active since they've been discharged from the hospital, so higher risk for dislodgement just because of the natural course of them being more active. VP shunt failure will show up with all of these complaints: headaches, vomiting, lethargy, irritability, swelling or redness along the shunt tract. Don't be too shy about saying, Mom, so which side is the shunt? And look at the back of the head. Mom, do you think this looks more swollen? They may complain that the kid has not been really acting the same at school, having confusion, new onset seizures. But like I mentioned, parental concern is my red flag. The top differential diagnosis is that there might be a shunt infection or viral illness. There could be medication besides having a shunt failure, the other differential diagnoses could be that there's an infection, maybe a viral illness that are causing these symptoms. Some of the kids that are on additional sort of long list of medications could be having some medication toxicity. One of the most common things we'll see is baclofen. A lot of the kids, particularly the ones with cerebral palsy, are on a medication called baclofen to relax their muscles. So in excessive amounts, baclofen could cause them to be quite sedated. And so that can be something to check if they have potentially a new provider that gave them an inappropriate dose. Or the reverse is that they missed a medication dose and now you're seeing the signs of that. When you're troubleshooting an obstruction or infection that's causing an obstruction, the signs there are concerning for increased intracranial pressure. That for us is a surgical emergency. And I am known in the ER when I'm on is that medications don't fix surgical problems. So while in increased intracranial pressure, many of us will think, oh, we can do mannitol, we can do hypertonic saline, we can hyperventilate. Honestly, at the end of the day, the definitive care for this patient is a surgical fix. So I talk here about hypertension, bradycardia, diminished respiratory effort. What is that referring to? Right, Cushing's triad. So that's a red flag in your communication with us if you're seeing those signs, in addition to all of the things we just mentioned. And so that indicates to us that there's a concern for increased intracranial pressure. We advise, if possible, when you're transporting these patients and your suspicion is raised for increased ICP, to elevate the head of the bed at least 30 degrees because gravity can work in our favor here. Ensure, as best as possible, adequate ventilation. When they get to the emergency department, we have immediate algorithms to do a stat CT, shunt x-rays. If it's very obvious, we'll have neurosurgery at the bedside. And at that same little sort of valve area right next to that, there's a port at which the neurosurgeons can come in and tap the shunt to take off at least some amount of fluid to buy them some time to go to the OR and then do a full revision of the shunt. So as you can imagine, calling neurosurgery to the ER is maybe not their favorite call. So the earlier heads up we can get from you sort of picking the patient up and giving us that warning, they can have us working on getting the neurosurgery at the bedside as soon as possible when they get here. The update here in the ED, though, even though the patient's seizure stopped while you were picking them up, when you got to the ED, they began seizing again, which is a telltale sign, and they were having slowed breathing. So we were convinced that this was shunt failure. We were fortunate to have, though, the shunt tapped in the emergency department. They went to the operating room with neurosurgery. They were admitted to the ICU, had improved symptoms, and these patients will often go home in not too much time and do quite well. Has anybody had to deal with a VP shunt malfunction or concern for malfunction in a pediatric patient? You have, okay. Anybody else? No. I will say that I feel like in my experience, and this is anecdotal, I tried to find the numbers for these, this patient population in terms of transport and how they get to the emergency department. These families know these patients so well. They often will drive here directly with them, which scares us because they show up on our front doorstep without any assessment, but certainly they will show up with these patients at our doors themselves, knowing that they need to get a pediatric neurosurgeon as soon as possible. So you may not get as many of these calls, which is why it's important I wanted to share this talk, because that one patient that you do happen to get that is a 911 call can be extremely scary. So this is my sort of take home for today. Really, the number one thing is that parents can be your best guide, particularly for kids with special healthcare needs, because they truly know them best. There are many times they name conditions that I'm like, I have never heard of this, ma'am. Please teach me and educate me. And you eat a piece of humble pie in that you don't know it all. And they can guide you through the care of their child's condition and what are the things that they have been taught to do to troubleshoot. You can ask for an emergency care plan, and we're really trying to reach out to our families. We actually have a program here called the Parent Navigators, which are parents that are the parents of kids with special healthcare needs that are employed by Children's National to help other families navigate the system so that they can understand the complexities of the different subspecialists, what they can get in the emergency department, and how to coordinate their care and their medical home outside of the hospital. And then use the hardware to your advantage, right? Some of it is a little bit of basic plumbing sometimes, not getting too overwhelmed by the complexities of the condition, but really using that dope mnemonic in order to sort of start somewhere is very helpful. And if we know that you've started to troubleshoot in that algorithm, it helps us pick it up from there in the emergency department. The tracheostomy is really clear-cut. It's an airway, so doing what you can to maintain patency, whether it means that you are, using suction, having a caretaker replace the tube. Those are some of the first sort of techniques that I would employ. The ventilators, sometimes just taking them off the ventilator and doing good old-fashioned VVM. G-tubes, yes, you may not be allowed to remove or insert, but remember the families are often trained in this if it's an older G-tube beyond 30 days. Otherwise, place some covering over it and get them to the ER as soon as possible. And then the VP shunts with some concern that if it's due to increased intracranial pressure, maintaining that head elevation to have gravity work to help you out. So I mentioned that I would give you a little bit of, yes, question?
There's a question online for these patients, the kids with shunt failures who are seizing pre-hospital, are benzodiazepines still indicated?
Yes, so we can use benzodiazepines. Now, some of these kids are likely to be refractory to benzos because they are usually on sometimes multiple seizure meds. But do what's in your algorithm or your protocol and then call for medical control. We are going to be trying to troubleshoot that as much as possible, but we have the advantage of potentially being able to offer get some neurology insights on what are some other things we can do. Hopefully by the time you get to us, we can have those meds ready if the kid is still actively seizing to be able to give them to you, because you may not have it on your trucks. Any other? Yes?
Where do you get copies of the emergency information forms for special needs?
Exactly that. If you Google emergency information form for special needs, it comes up as under the American Academy of Pediatrics website, but there's a lot of other organizations that hyperlink it to the AAP website. So that's a good question. Yes?
We've been talking about these patients with special needs managed with technology. We've got, for some reason, enough patients in our jurisdiction with adrenal deficiency disorders. Sodium chloride is what they carry. We don't carry sodium chloride. What's the discussion as to alternatives?
So really on your truck, that's going to be very tricky. Yes. So the question is that we have not discussed some of the patients with medical complexities of things such as adrenal insufficiency and having complex medication needs, like if they're in a crisis and needing their steroids. And the fact that you don't carry that on the truck. If you don't carry it, you don't carry it. I think.
We have sodium instead, though.
Oh, so Honestly, my safest answer for you is to call for med control, because I don't want to speak for the different jurisdictions and what they would do, but calling for med control will be helpful to guide, because sometimes depending on the time, it might be just to get them here as soon as possible, or they may be able to give some advice on Solumedrol. Yes?
And steroids take hours.
Yes, exactly.
Hours.
Steroids are not a rescue medication for the most part. So while we would want to start treatment as soon as possible, of course, you know, I think the safest thing is to get them here as soon as possible for the appropriate medication and dosing. Any other questions? I have a few minutes, I believe. I wanted to speak a little bit about the Emergency Medical Services for Children's program. First of all, how many of you were here last year? Oh, okay, great. So you'll rehear some of this of what I'm talking about. The Emergency Medical Services for Children's program, how many of you have heard of that? Oh, I was hoping more of you would. Well, we're doing our best to sort of put ourselves out here. So you own this program. These are your taxpayer dollars. The Emergency Medical Services for Children's program is it's a little younger than me. It's a 30-something years old. And it was issued as a federally funded mandate many years ago to improve the coordination of care for children in the emergency setting, the entire realm of the emergency setting. So while it starts with EMS and in the home, it also means that we work with emergency care for kids in the emergency department and through the hospital into rehab. The federal funding is issued to every state and territory in the US as an allocated amount of money that goes towards doing things like assessing how ready various entities are in caring for kids, including EMS systems, emergency departments, not just pediatric hospitals, but general emergency departments, trying to raise the bar so that everybody is aware of how to troubleshoot distress in a child, because children can show up anywhere in the emergency system. And then providing resources. So we're building our website. You'll see it soon, because we're the EMSC program for DC, and there's 3 of us that run the program. But we're building a website now linked to Children's National Will. You'll be able to get things like the emergency information form, information about sort of talks that we give. We've come out to Virginia a few times. We're linked to a medical reserve corps as well that we are work in sort of a disaster setting to educate providers on being on the front lines and caring for kids in mass gathering events, for instance, doing things like Stop the Bleed, and really trying to be there as a resource, because dollars that are paying for this, and I think it's highly needed. If you have ideas about ways that the EMSC program can offer support, and there's a Virginia EMSC program and a very robust Maryland EMSC program for those of you from Maryland. If you have ideas of ways that we can provide support to your system services, come out, do education or outreach, that's something we are trying to build now. So I wanted to put myself out there, not just as a resource to answer these questions, but also in that regard. Okay? All right. Any other questions? All right. Thank you, team.
that off.
It is on. You can't hear it because it's not going to them, it's going to the live stream.
I see. Well, I just made some people deaf. Sorry about that, y'all.
All right, welcome back. You guys enjoying your day? Okay. My name's Cindy. I've been kind of like behind the scenes.
Hello. Like Cindy said, I'm a service resident here. I volunteered to do some education and was often told that it would be blast injuries. So this is mostly based off of a fireworks injury presentation that I already gave. So a lot of it's going to be very fireworks centric, but there is some other stuff in there. So just a little bit about the physics of a blast injury and kind of the clinical implications that we need to think about as providers. First and foremost is the blast location. So if you consider a wide open area, the impacts of that blast wave are not going to be as focused. They can be kind of much more dispersed. The impact area might not be as significant versus a blast that's occurring in an enclosed location. You now have kind of a container to kind of focus those blast waves, and then the reverberations can kind of cause worsening effects. Additionally, common sense would dictate that the person closest to the bomb is going to have the worst injury. Indirect relationship, distance, and the effect of the bomb. Just the topics that we're going to talk about in terms of blast injuries in children. Fireworks, probably the most common due to their commercial availability. Cell phones, e-cigarettes, and then of course, with the unfortunately increasing incidence of mass casualty events, we always have to consider terrorism. So, everyone say it with me. Ooh, ah, it's all very pretty. And sometimes kind of sucks. So don't hold fireworks, y'all. So this is a video that we'll just kind of put into perspective for pediatric patients.
It's a lot more difficult to fly this drone with broken fingers. But Curtis Muswich's right hand is a lot better off than his left.
The palm of my hand and my pinky. The rest of it is gone.
A week ago, he and his friends came here to Firecracker Alley in Tacoma. Muswich says he found a used mortar that looked like it still had some fuse left. He lit it, and it exploded in his hands.
All I heard was a ringing.
I was in shock. I was panicked.
Florence Mason says she first saw her son in the hospital. She learned he would lose most of his fingers on his left hand.
He's a trooper. He helped me. He said, Mom, I'll be okay. Things will be fine.
Muswich says he'd be blind too, if not for his sunglasses.
I didn't think about what could happen if it went wrong. Think about it. Which I hope other people, after seeing this, would actually think before they do. I think that's probably the big lesson. Think before you do.
He hopes other teens will learn something from his story.
Well, if you see a firework on the ground, leave it alone. If you use fireworks, use brand new ones, not one you saw me.
Muswich says he's done with big fireworks. To stick.
Go any worse?
In Lakewood, I'm Allison Morrow.
Okay, so that was a prime example of some teenager logic for you. But fireworks are no joke. These are some of the PSAs that are put out by the CDC as well as a bunch of other departments, basically saying fireworks, even when handled correctly, can be very dangerous. There's a significant damage caused by fireworks year. And then if you think about who's going to be injured from fireworks, the most commonly injured age group is going to be children under 4. The next group is going to be kids between 10 and 14. And even innocent-looking fireworks that you might to play with in the yard, like a sparkler, it burns at 1200 degrees, so that can cause significant injury. So we're just out of fireworks season for a little bit. We got a little bit of a reprieve. Fireworks injuries every year, with about 7 deaths each year. And usually the deaths can be attributed to either careless use or misuse. And then in terms of when different areas are going to see more fireworks injuries, you got to think about the big holidays. So in Asian countries, it might be around like the Chinese New Year or other festivals. In America, it's going to be 4th of July is the big one. So about 15 days before 4th of July, 15 days after 4th of July. And then New Year's is you see a peak in fireworks injuries. I know that I was on call on 4th of July this year, and we saw at least 12 in the ER. So just looking at kind of the trend in fireworks injuries, they were decreasing in time until about 2010, but now we're kind of seeing an increase in the amount of fireworks injuries again. And like I said before, the injuries tend to come from malfunction of the fireworks as well as misuse. So malfunction could be you set it up appropriately, you're doing everything correctly, but then the firework that you've placed on the ground and lit tips over and shoots out at people instead of shooting up in the air. They can fly in the wrong direction, they have short fuses, or the firework itself can just malfunction. So instead of projecting the aerial display, the actual firework canister, the firework, usually a paper tube containing the explosive, blows out and causes injuries at ground level. Or misuse. So improper lighting, mischief, putting it in your hand and lighting it, or thanks to programs like Jackass, putting it in some other location of your body and lighting it. So, your fireworks injuries, again, are going to be affected by what type of firework it is, where it was, where you are, how old you are. And so, children younger than 15 account for a disproportionate amount of the fireworks injury burden. Gender, it kind of makes sense that it's mostly going to be boys mishandling it, versus when females are injured, it tends to be more commonly at public fireworks displays. So things were set up, a spark goes the wrong way, catches a bystander, or there's shrapnel that and the kind of firework is also important. So like I said, even though sparklers look very innocent, they can be very dangerous. So we see about 900 sparkler injuries a year in America. So like I said, disproportionate amount of children are injured by fireworks. With, if you just break it down by gender, the highest rate of injury being and this is because, they're lighting them in the street or they're at a park. This is obviously a very young child who should not be playing with fireworks. Your body parts most injured, head, face, hand. Significantly increased amount of morbidity and mortality associated with injuries. You think about So moving on to cell phones. I just love this GIF. So cell phones. Before we even think about cell phone blast injuries, we can just think about, the amount of trauma that cell phones can be associated with each year. 1.6 million car accidents per year are associated with cell phone use. If you break that down, about 390,000 are associated with texting and driving, and texting and driving actually accounts for about a quarter of all car accidents. Because if you think about it, you're traveling 55 miles per hour, your attention gets diverted for 5 seconds, you've traveled the length of a football field. And then there's texting and walking. So this even causes a significant amount of injury. It causes about 11,000 injuries a year because of what's called inattention blindness. So you're so focused on one thing, you don't really know what's going on around you. As you can see, this guy here is texting and he falls onto the train tracks. He's lucky that there were people around to pull him back out. And then, kind of the purpose of bringing up cell phones is cell phone explosions and cell phone fires. They're not as common as fireworks injuries, but they do happen, and they tend to be pretty dramatic. So in the past, we've seen these headlines. 12-year-old dies after cell phone battery explosion. Cell phone causes fire at Hackettstown Hospital. Woman's bedroom catches fire after she leaves phone charging on mattress. 11-year-old girl says her iPhone begins sparking in her hand, leaving holes in her blanket. And iPhone battery explodes, injuring teen with burns. These are all just since June. April, I lied. So if you think about cell phone blast injuries, why they occur. Usually it's because of using kind of cheaper knockoff products and associating them with a cheaper knockoff charger. However, because cell phones are getting thinner and thinner, you also have to think about your thin lithium-ion battery, where there's less distance between the positive and negative plates of the battery. And so as kind of everything heats and expands, you might be bringing those two poles that should be separated close together. Additionally, there's an increase in cell phone explosion and cell phone fire when the phone is being used while it's charging. So we have first case report, a 10-year-old male. So he was playing with a cell phone that was plugged into a charger. There's no EMS report because his parents brought him in, but the initial presentation was that he was alert and oriented ×3 with stable vitals. What the parents said was that he had the phone and it exploded in his hand. So the third finger, as well as a significant devascularization of the fourth finger. And then you've got thumb, pointer, pinky. Okay. So they did a free flap with skin from his thigh in order to cover that defect. They were able to salvage that first finger despite the significant amount of injury to it. And at 6 weeks, had healed to that. So somewhat of a... And then if you look on the CDC as well as other cell phone manufacturing sites, what they recommend, and I can tell you that I'm pretty sure I broke rules last night alone. Avoid carrying your cell phone on your body at all times. Keep it near your body, such as on a pillow or bedside table. Avoid using your cell phone when the signal is weak or when you're moving at a high speed. Always buy standard battery and charger. Never charge your phone overnight. Charge it when you're awake. So who's broken at least 2 of these rules? Everyone. All right. So, again, we say that we can prevent it, but cell phones, we have to have them on us at all times. So you might see some cell phone injuries, and now you have a little bit of knowledge about it. Moving on. So unfortunately, e-cigarettes are also becoming increasingly popular in the middle school and teenage population. This was actually a wine store, and his e-cigarette exploded in his pocket. Pretty impressive. All that wine. That would have not been awesome. So, e-cigarettes. They're becoming increasingly more popular because, you know, battery and a heat source. To routinely using e-cigarettes or vaping, and alarmingly, about almost more than half of have also admitted to doing it. About burn or explosion injuries over 2 years from 2015 to 2017, and the pattern of injury that's commonly seen is going to be to the eyes, hands, and mouth. So you think about kind of where the proximity is if you're using an electronic cigarette. So, another case report, 17-year-old male, presented to the trauma bay with jaw pain and swelling 2 hours after an e-cigarette exploded during use. The report that we got from EMS was that he was hemodynamically stable, no respiratory distress. And then the description of his injuries, he had puncture wounds to his chin, extensive mouth laceration, and then the avulsed teeth, which you can see. So he underwent a CT. This is the 3D reconstructed images, but he, on top of losing teeth, also had a significant mandibular fracture as well as his teeth. And so he underwent open reduction internal fixation of his jaw as well as splinting of those bottom teeth. And then kind of less entertaining, as much as, talking about the odd cell phone explosion or the e-cigarette explosion, is kind of the unfortunate realism of terrorism and kind of the threat in the country. So this is a picture from the Boston Marathon bombing back in 2013. So using that as a case study for this presentation, at almost 2:50 p.m., two brothers exploded 2 homemade pressure cooker bombs about 12 seconds apart, and they were about 200 yards from the finish line. These bombs were loaded full of a bunch of metallic items with the intent to cause as much injury as well as much chaos as possible. And there were 3 deaths at the scene, one of which was an 8-year-old boy. In the aftermath, there were numerous first responders on the scene who were credited with saving many, many lives. But what they were dealing with was traumatic amputations, penetrating injuries from what had been packed into the pressure cooker, crush injuries from structural damage that had fallen onto victims, as well as burns from those who were in close proximity to the blasts. There were about 264 patients who were treated, and even Boston Children's saw an influx of patients. So what they saw were the 9 child patients who survived. A 2-year-old who had very significant head trauma ended up staying for quite a long time in the surgical ICU. A 9-year-old female whose leg was barely saved, but was saved. A couple femur fractures, another mild TBI, another leg injury, and then several other mild injuries. So even when you consider that the majority of patients were adults, the impact of terrorism on children is still pretty significant. Basically what they described injuries as is that they were akin to those from a battlefield and not a spectator viewing stand. And unfortunately, some of the more some terrorists with more perverse ideas might in fact target large populations of children with the idea to cause increased chaos and increased harm and alarm. If you think about the Oklahoma City bombing in 1955, where Timothy McVeigh detonated a bomb at a federal building, one of the targets was a daycare that was adjacent, and 19 children were killed in that attack. And then if you think about another event or young children, would be a concert. So there was the Ariana Grande concert in 2007. where someone carried out a suicide bombing, and 7 children were killed and 16 were injured amongst the other victims. Kind of went through the scenarios that might be most common where you would see blast injuries in children. Again, the far most common would be the fireworks injuries. But then think about the injury pattern. So with any blast injury, you can break the pattern down into 4 levels of injury. So primary is going to be kind of your gas-filled organs, and it's going to just be from the wave of pressure. Secondary and tertiary are going to be more from things being thrown around. So either things being thrown at the person or the person being thrown into things. And then quaternary are your burns. So we'll go through each of the injury types. Primary injuries, like I said, is going to be for your gas-filled organs. It's the barotrauma that ends up causing this. The most common is going to be a tympanic membrane rupture. So particularly patients who are close to the blast wave, but even those who are very far out, especially if it's in an enclosed space, can suffer from this. And the presenting symptoms would be hearing loss, ear pain, vertigo, tinnitus. And in that picture you can see a perforated TM. Kind of more devastating, and what's one of the more fatal primary injuries from a explosion is going to be blast lung or the pulmonary injuries. So this is increasingly more common when explosives are used indoors. I remember treating a patient who had a propane tank explode in his shed, and while his cutaneous burns were relatively minor, we had him intubated for almost 2 weeks just trying to manage this pulmonary injury. And so these patients can present with respiratory distress, hypoxia, there can be associated PEs or pneumothorax or air embolism. It's just very hard to ventilate, and there's a VQ mismatch with the pore gas exchange. You can also see cardiac blast injuries. So even though it's a muscular organ, it's still got, wall and then liquid. And so you're going to treat this very similar. However, in explosions, your cardiac blast injury may not be associated with kind of the external signs. You could see a bruise on the chest wall, you could see a fractured sternum, but that's not necessary. In terms of their lab abnormalities, they might have elevated troponins, they might not. However, if you get an EKG and they've got an arrhythmia on the EKG, they need to be managed for a blunt cardiac injury. Very uncommon, but can happen when you're thinking about that primary blast wave. You can also see gastrointestinal injuries. This is more common when you think about like deep sea divers or ships. However, it does happen. And so if you think about, how they're going to present, may not see a bunch of external trauma on the abdomen, but they've got pain that doesn't really make sense and they're peritonitic. Or you could have hemorrhagic shock from a solid organ injury, which you can see the bleeding in the picture here where you've got blood between the liver and the kidney. And then the initial resuscitation for these patients is going to be very similar to all your trauma patients. Fluid resuscitate. In adults, they're going to get a fast exam performed. In children, they're not. But if they've got abdominal pain that doesn't make sense after a blast injury, you should be considering a CT scan. Then moving on to secondary and tertiary injuries, which are the more common injuries and what we think about when someone is involved in an explosion. And this is termed the blast wind. If you break it down into secondary and tertiary before kind of talking about these injuries together, secondary is from objects striking the victim. So with the Boston Marathon bombing, the nails and all the other shrapnel that was packed into the pressure cooker then exploded out and almost became like multiple thousands of bullets from a gun, causing penetrating trauma to whomever they hit. And so just like a bullet, if it hits you in the right spot, this can cause significant hemorrhagic shock and can cause death. But it's not, the speed at which these objects are traveling can somewhat be prevented by clothing. So a lot of the penetrating trauma was seen mainly on exposed areas, face, neck, arms, and legs. Versus the tertiary blast injury, now you're talking about the victim being thrown into objects. So that blast wave can actually create enough force to pick up a person and throw them into something. This can also be associated with structural collapse, which can then have objects fall on a victim, causing associated crush injury. So when you're thinking about secondary and tertiary injuries, especially when you're talking about like smaller explosives like fireworks, a lot of the time you have to be concerned about like eye injuries. So 2/3 of these eye injuries are going to involve the cornea. In children particularly, trauma is one of the main causes of monocular blindness. And bringing this back around to fireworks, which is going to be something you'll see, 20%, which looked at eye injuries during their fireworks busy season. And of course, as predicted, 4-to-1 male to female ratio, average age just shy of 10 years, and there was a pretty significant morbidity associated with these injuries, with 8% having permanent blindness. Fireworks even can just shoot back, and the spark can cause a burn around the eye, because the issue is that an explosion or a burn is much faster than your blink reflex. And so where your eyelids might protect you from a scald burn, so water being spilled on your face, they're not necessarily going to be able to protect your eyes from an explosion. Looking at our own trauma manual here, we typically recommend against children with facial burns getting an ophthalmology consult, except in this circumstance. So children with just a scald injury, hot coffee, hot tea spills off the counter onto their head, even if they've got a periocular burn, they're not going to need an ophthalmology consult. Children with a periocular burn from an eye injury or from an explosion will. Like I said, it's the eyelid reflex, fastest reflex in your body, but it's not fast enough to prevent a thermal injury from an explosion. Treatment recommendations for eye injuries, more kind of in the emergency department side. They should get a eye exam as well as the dye test to look for corneal abrasions and globe injuries. And then you don't want to test the pressure of the eye until a globe injury has been ruled out. And then mainstays of therapy are going to be flushing the eye, pain control, preventing infection, and then lubricating. Moving on to hand injuries from handheld explosives. Most of them, again, are due to inappropriate handling or premature explosion of an explosive device. The common pattern is going to be injury kind of in this area right here, where you fracture the thumb, destabilize the thumb joint, but then there's significant tissue damage kind of in this web space right here. Sometimes that can heal fine, but if you lose enough tissue here, you can get what's called an adductor contraction, where the thumb is kind of almost held away from the rest of the hand. And so you can kind of see it here. You've got the fracture, the destabilization of the joint, and then the significant web space tissue loss. This was a retrospective study over 10 years of patients who had operative hand injuries from a firework explosion, and about 85% of them sustained that thumb and first web space injury, with a quarter of patients requiring actual amputation of their thumbs. The handheld explosives like shells, mortars, those are the ones who are going to be most contributory to these hand injuries. So this is just kind of one of the pictures from that article. This is the very common injury that we already saw. And then this is how it was reconstructed with a free flap, and then you can see the partial amputation of the thumb. That leaves an overall pretty functional hand if you're lucky enough to A, only have that damage, and B, go somewhere where there's hand surgeons who can reconstruct it. Or if you handle a firework, sometimes you can get that. Not really any salvaging that. Last but not least, there's the quaternary injury associated with fireworks, and remember that this is the burns. Or sorry, with any explosives. And like I said, this was originally a fireworks presentation. So explosion burns. They happen in 3 ways. There's the flame burn. So as with most explosives, there has to be fire to light it. And then they usually set off sparks or propel sparks, and so those can catch clothing and cause burns. There's the chemical burns that's associated with the explosive components of the explosive device. So right here in this picture you can see it's actually a phosphorus burn. And then there's the heat burn, which is just from the sheer temperature of the device. And that's going to be what's usually associated with your concomitant blast injury. If you think about kind of the scale of skin burns occurring with just hot water time, that water of that temperature has to be in contact with the skin to cause burn. So immediate contact with boiling water at 100 degrees Celsius is going to cause a significant burn. But then you think about fireworks or other explosives that burn at almost 700 degrees Celsius. Second contact with the skin is going to cause a burn. And so these are burns. I think the middle one is one that we treated here. The rest of them are images that I got offline. But hand burns are kind of a significant cause of morbidity associated with fireworks and other explosives. And even that innocuous sparkler burns at 1200 degrees Fahrenheit. If you think about burn and blast injury together, this was a retrospective study of 32 hand burns from fireworks. More than half of the patients were children between 5 and 14 years old, and 94% were male. Bystanders are less frequently injured than those actually using the firework, but they can be injured. And like I said, the burden falls disproportionately with the children. So I think this is the last case report, but the 4-year-old male presents to the trauma bay as a trauma stat following a fireworks injury. Per EMS report, the patient admitted to lighting a firework in his apartment laundry room, and it started a fire. The firework itself had gunpowder in it, and it was one of those models that was designed to be shot 150 feet in the air. So lit it in an enclosed space by a child. We're not doing too hot. So the patient was stripped of his burning clothing and received a normal saline bolus en route. On physical exam, his eyes were normal. He thankfully did not sustain any blast injury to his ears. His TMs were non-perforated. He was not having any abdominal pain. He did have scattered shrapnel abrasions as SA burns. So these are the burns that he had to his leg. And you can kind of see some of the speckling from the gunpowder that was in the explosive device. And then the burn that he had to his torso. He did pretty well. Got ketamine sedation in the ER. His burns were dressed with Xeroform and Meplex, and was actually discharged to home on burn day 2. In clinic, transitioned to Sylvanine, then back to Xeroform, seen in burn clinic a couple times, and then was discharged from burn clinic with healed burns about a month post-injury. But even innocent victims can be kind of harmed by fireworks gone awry or the burns associated with explosive devices. So this was an article out of, I believe, England, where a little girl was at a fireworks display and kind of a burning ember shot back at her, got caught in her scarf. So, in conclusion, takeaways from this lecture. First and foremost, again, most common thing that y'all will see, not in a war zone, hopefully with no terror around, is going to be fireworks injuries. Cell phones and vaping, not as innocuous as it seems, and then there's always, unfortunately, the risk of a terrorist attack. But bombs and explosions have a unique injury pattern, especially considering those handheld explosive devices. Penetrating and blunt trauma is going to cause the stereotypical blast injuries that you think of. However, once the bleeding has stopped and the burns have been treated, the most fatal injury among survivors is going to be that blast lung. Explosions in confined spaces are very deadly because of that secondary blast wave and structural collapse, people being thrown into things. And then in terms of triage, the most severely injured patients are probably going to be on scene for a little bit of time, either being dug out of the wreckage, being stabilized. And so the initial influx of patients are going to be maybe less injured than the ones that you see an hour out from the explosion. And so you have to manage your triage resources appropriately. That's all I have. Any questions? Nope. All right.
Are we expecting to see less incidences of e-cigarettes and stuff exploding with newer technology and batteries, or is lithium here to stay?
So I can't speak truly to that, but the issue with any battery, watch, like Apple Watch, the phones, the e-cigarettes, it's the heat with the battery. And so that's part of the reason why, you don't want to, when you're charging your phone, you don't want to have it on a heat absorptive source, or where there's some danger in leaving your phone in the car on a hot day. It's kind of as elements heat up and expansion occurs, you can create those explosions that if in a cool environment wouldn't have happened. And so charging heats up your phone. Vaping, the smoke, it heats chemical. All right.